first of all. Can I check, please, that all members can see and hear the other participants? We do have Councillor Baker joining us this morning. I know he's very interested in mental health, so I invited him to our meeting today. Please note that this meeting is taking place as a virtual meeting only, with access to the general public, and that the sound from this meeting is being webcast and will be available on the ECC website after the meeting. Although ECC is making an audio recording of this meeting, members should be aware that anyone attending this meeting, either as a panelist or an attendee, could make a video recording of all or any part of the proceedings. Please also note that this meeting is being streamed live via the ECC Democracy YouTube channel. More details are set out on page 1 of the agenda. I ask that you all treat this meeting as if you were in County Hall and pay full attention to the meeting and do not take telephone calls throughout its duration. There are 4 main substantive agenda items, and I'll go through those as we get to them. Questions will be taken after the reports and presentations have been made by members. I will ask members to use the electronic raise hand function. Everybody's microphones will be muted whilst reports are being made to prevent background noise being heard. I'll leave you to unmute yourselves. Thank you very much indeed. Do we have Jill Burns with us yet this morning?
Yes, she's here now.
Yeah, right, that's fine. Just so that I know where we are. So that said, I'm going to go to agenda item 1, which is membership apologies, substitutions and declarations of interest. Richard.
We've received no apologies. Sorry, we have Councillor Helm, as he declined the meeting invite, so we've taken that as an apology.
All right, thank you very much indeed. Declarations of interest, please, members. Councillor Egan.
Thank you very much, Chairman. Yes, I have a code interest as my cousin is the Managing Director of Basildon Hospital Trust.
Thank you very much. Anybody else? No? Councillor Brown.
My son is a consultant surgeon at Southend Hospital.
Right, thank you very much indeed. Moving on to the minutes of the meeting held on Wednesday, the 4th of November. Page 8. Any pressures? Which was just the one main item we had that day. Page 9. Page 10. Can they be signed as a true record of that meeting? Thank you very much indeed. I'm not aware that we have any questions from the public. Would I be correct, Richard?
That is correct.
Right, thank you very much indeed. Right, well, I would like to move on to agenda item 4. My paper's up there, which is mental health services. We have Jill Burns, who is here, who I'm going to ask her to present first. Good morning, Jill. How are you?
Good morning. Can you hear me okay?
Yes, and we can see you as well.
Oh, good.
So I will ask Jill to present first, and then I'll get the members open up the meeting for questions. And we then have Sue Waterhouse from EPUT, Eugene Staunton, North East Essex CCG, and Peter Whiteman, West Essex CCG. They have a joint presentation, so I will then get them to present and then open up the meeting to questions after that. So that keeps it a little bit more orderly. So Jill, over to you. Thank you very much indeed. I cannot believe it was September that we saw you last. The time flies.
Honestly, me neither. So I'm hoping everyone has a copy of a brief PowerPoint presentation that we submitted a while ago. Yeah, I see lots of nodding heads. So what I'm going to do, if that's okay with members, is just to take a sort of quick walk through the slides. And I know then that members normally have lots of questions. So Helpfully, after the last HOSC meeting, I'd been given a list of areas to focus on for the meeting. So I've kind of done a slide on each to keep us all on message. So the second slide as the key areas of focus, which were an overview from a NELF perspective and primarily children's mental health on a response to the pandemic and an update on that, future planning around changes in demand, etc., what the access target looks like, which is an area of hot debate at the moment, impact on staffing capacity across the Essex footprint in relation to services. We'd been asked to just give a breakdown of referrals and people in treatment in relation to the type of mental health conditions, and then a slide on suicide. So I'm going to move us on then quickly to the COVID update. So I'm sure, like my colleagues on the call today, I'm sure none of us expected to find ourselves in the position we are now, midway through wave 2, albeit with some light at the end of the tunnel with the vaccine. I've seen the news today, and we're talking about some vaccinations starting in the next couple of weeks. So NELFT has a major incident command and management structure. I'm sure my colleagues in EPIT will update on a very similar vein. All foundation trusts have to have a major incident command structure up and running throughout any kind of emergency. I think this has been rather unprecedented, where we've had to maintain business as usual, plus run on incident management for the entire year now, really. Our future focused tactical groups are in place. They were tactical groups that we got up and running over the summer when we came out of phase 1. We're hoping not to be moving into phase 2, but had our future focus groups up and running in order to get us ready to recover from where we had been. That being said, for children's mental health, we did not step down any services as I outlined the last time. We just delivered them in a different way. But in many areas, some of you will be aware, in paediatric services, a lot of non-essential, as deemed by NHS England, front-facing services were withdrawn, and all those staff were redeployed, some of them to COVID hospitals, etc., across Essex. So we've had very active engagement across the whole STP footprint. We have a Mid and South Essex workstream, which my colleagues in EPIT will also be very familiar with, in that it's been rather refreshing on this occasion that all the main providers across Essex and commissioners across Mid and South and our Essex County Council colleagues have really all worked as one system. Now, a very good example of that is in adult provision, where we all joined together to run the COVID hospitals across Southend, Thurrock, Mid Essex, whereby all the providers joined together to provide staffing, management, etc. So I think that's probably an important point to note here. As I've said, all services remained open and business as usual, and we actually went to quite a lot of lengths to get that message out there, because I think there was a bit of a message around schools and children that services weren't open and GPs weren't open, and that's absolutely not the case. We had virtual contact for most initial appointments in order to ensure that we kept within correct timescales. We did reviews and treatment digitally or face-to-face based on clinical need. For example, any children that would have presented at A&E, which is obviously the last place we want children to go, obviously all the crisis service continued working face-to-face with appropriate PPE and COVID protection. We did very robust operational monitoring of caseload management and waiting times, particularly during the COVID episode. After we came out of phase 1, we had an awful lot of staff that were all shielding. So we wanted to make sure that we weren't building up internal waiting lists, which I'm very pleased to say we have not. I think it's been a bit of a double-edged sword, if I'm honest, because in some ways our staff will say to us, and I'll be interested to see what my adult colleagues have to say about this. Some of our staff say that operating digitally has been more time-consuming in that they've had to have longer appointments with patients because you don't have the natural flow back and forth of a conversation just as much digitally. That being said, they've been able to see a lot more patients because they have a lot less travel time, etc. Although formal contract and performance management meetings did not take place for any contracts during COVID for NELFT or any other provider, we did within Children's Mental Health continue to monthly meet with our lead commissioners to give an overview of where we were and to provide some assurance around referrals, any particular trends, pressures on A&E, etc. Okay. So I'm on to the next slide now. I think it's number 4. So what have we been doing around future planning and demand? What we have seen this year is perhaps not unexpected. We've seen a lot more acuity, a lot more complexity. We've seen a lot of patients presenting crisis that we've certainly not known those patients before. So they're not patients that have been on our caseloads that have suddenly had a spike in their condition. I don't think it's any secret, and I'm sure I outlined this, or I hope I did at our last meeting, that we did anticipate across children's services nationally quite a spike in referrals, and we have seen quite a spike in our referrals to treatment and our crisis management. We've been busier in our crisis teams in the last 2 or 3 months than we have all year. Obviously, that puts quite a pressure on everyone. Interestingly, I've just come off a call this morning with managers looking for some escalation calls with our Essex County Council colleagues, because we've had quite a lot of children who have had placement breakdowns, such as the LAC children. So one of the main things that we've been working on, myself, Chris Martin, Paul Secker, a few others, Tina Russell, Sharon Hall, is looking at a real quality and clinical review of the pathway for looked after children. And that is not a NELFT alone piece of work. That's doing that in partnership with Essex County Council. And we've moved some way in looking at 10 sort of high risk cases and how we're managing those and doing something different. In fact, in one area of the county up in the northeast, we're looking at a kind of seconded role with social care to manage really complex children. And I understand my adult colleagues are moving down the same sort of management clinical model for adults. We reviewed our single point of access, which happens to be based in Colchester, but could be based anywhere. And we had a real thorough review of all the integration opportunities, digital offers at the front door, really trying to provide lots of information and support from the moment that you dial into the spa. We have had to put some additional resources at the spa at the front door just to manage the volume of work coming in to make sure we do a full clinical triage. We've done a lot of joint provider work to improve our LD pathway and our physical health monitoring across the piece. We have a bit of a strange situation, if you like, and it's not unique to Essex, but a lot of children who would be receiving medication within children's services, ideally or in the longer term, you'd want to normalise that treatment and have a lot of that prescribing done in primary care with a review perhaps biannually by specialist services. But we do have a lot of issues across the Mid and South Essex footprint, where we have a lot of resistance from some of our primary care colleagues who don't feel that they have the correct knowledge base to manage some of the children. So it's a piece of work that we have our senior pharmacists working on with our medicines management across the CCGs, because it's quite important that I think we kind of work on that as a system going forward. We also had a real review of clinical formulation and deep dive across the piece, because we had opportunity to do that when we were working in a different way during COVID. The collaborative working via the STP footprint for the most complex and high-risk cases has been well embedded now this year. And I think it's really forced our hand a little bit, because we've seen a lot more of those children coming forward. We've embedded some shared care protocols on children and young people with autism and ADHD. and that's been worked on by myself, the managers, and our pharmacy colleagues, and that's just to really try and help us in how we prescribe and manage some of those children who are often open to numerous providers. Our crisis offer, I think I updated guys the last time, that we tried to divert people away from crisis and used one of our services as a bit of a base to run up until midnight, so that anyone in crisis, unless they had a physical health ailment, could come and see us there instead of going to A&E. We then worked with our commissioners to look at our access targets. We embedded a new digital provision along with commissioners called Silver Cloud, and that works with our SPA, and it's another kind of digital support offer at the front door. We uploaded a lot more digital support mechanisms on our platform, and we do work very closely with an organization called Together All. It used to be called Big White Wall. It's really well known internationally, and they've been very busy. We've actually done a bit of a deep dive with our Together All colleagues, looking at when the service was most used. And interestingly, we had a high proportion of young people in the 16 to 18 year age group or bracket accessing that type of information during the small hours of the night when they probably can't sleep and are sitting alone in their bedroom with their iPad. Because as we know, for our teenagers and young people, the whole digital world is something that they feel extremely comfortable with, probably much more than in adult mental health for some people. We've also continued to try and do some workforce development opportunities. As you know, NELFT is the main provider or the only provider for the mental health in schools workforce project across Essex, and we've been successful in getting 7 teams. So despite the fact that schools were closed, we continue to manage those services digitally and try to develop that new model. I'm on to the next slide now, which is slide 5. And the reason I wanted to just mention this is something that's a real hot topic nationally about access targets. And people get slightly confused between what the access target is and whether a county is meeting it and what our actual key performance indicators are. So the access targets are actually a target that's really levied on commissioners to look at the population of children of the county and say, okay, in order to meet the access target of 35%, which albeit sounds rather low to all of us, that is the ambition for children's mental health due to funding and legacies over many, many years where there's a great disparity between children and young people's mental health funding and adults. So the ambition is that 35% of the population that require an intervention would be seen within children's mental health. That's not a target that's levied just against NELFT of a provider. It's really about a range of providers, including some of those digital offers and voluntary and community sectors. So it's really a population target, if you like. The fact that NELFT, as the main provider for children's mental health, has an open front door means that we don't actually have any roadblocks in the way. So there's nothing to stop people accessing our service. And as we know, the criteria is very broad as well. So I just thought it was useful to mention that because you see it mentioned all the time. We're very much on trajectory to meet all our targets. There was a bit of a dip earlier on this year, but as we have been discussing with NHS England and our commissioners, that is because the available population of people that we could see dropped dramatically at the start of the year because of COVID, i.e. people voted with their feet a little bit and did not come forward for treatment, which is why we think we've got quite a surge later on this year. And that's a picture that's been seen across the piece nationally. So I'm on to slide 7 now, and we've been asked to give a little bit of an overview on staffing and capacity. Just to say that we have approximately about a 20% vacancy rate, which we fill with bank and agency where appropriate, which obviously is not ideal, but is not dissimilar to any other area of NHS staffing at the moment where everyone runs with a fairly high vacancy rate. What I'm more pleased to say is that we don't have a big turnover with our staff, which is quite good. And we are looking at all new models as to how we manage the workforce and train the workforce. And that includes all the training, university-based training in psychological therapies, which is part of the Mental Health in Schools project. So that's another 56 staff, all of whom have not come through the traditional NHS training sort of rungs on the ladder, but have now a new model of training for 1 year intensive therapy, CBT. And then we bring them in to work within the school environment under very robust supervision. What's interesting here, probably not surprising, I'm not going to read it bit by bit, but it's for people's information. You can see the shielding at the start of the year and how that has really impacted. However, just because our clinical staff had to shield, they were still able to manage their caseloads with digital video consultation with patients. As we saw later on in the year, we had a bit of a spike around the kind of self-isolating patients because a lot of them had then children going back to school, etc. But the availability of the workforce has not been affected dramatically. We have had peaks and troughs, but we've been able to continue to run services as normal, which is obviously our main preoccupation. So on to slide 8, if we look at capacity and demand, we've had a much higher referral volume, approximately 800 referrals per month. So if you look at the September 20 line at the end, where everything is RAG rated green, amber, bar one little dip at red, which I will explain, that tells me that our staff are working extremely hard and being extremely efficient in managing to continue the throughput of referrals coming in, assessing children, seeing children within 18 weeks, assessing them within 4 to 8, and over 8 weeks. What you will see there in the middle group of data is that you tend to get a bit of a pinch point. People that have to be seen within the first 4 weeks are normally the fairly urgent children, and we meet that target at green. Then you get a bit of a dip in the 4 to 8 weeks because that's the kind of people that are falling a bit between I'm not urgent and I can wait for treatment. And then once it pops over 8 weeks, there's a big rush to make sure that we're trying to get through all the treatment of those children. But remembering that we've had a much higher referral volume, but we don't have additional staff. We're just having to keep people working in different ways at a much higher pace with a lot of throughput. What's been really crucial to us during this pandemic has been having our 24/7 crisis access and our Together All 24/7 digital platform. We have had increased demand on our crisis, where we're seeing approximately 200 children per month, either in A&E or in their own homes. We've had a lot of crisis visits out to children's social care placements, where the care is breaking down due to the complexity and acuity of the children. So there's been a lot of demand, and a lot of demand for CETRs, which are a kind of emergency treatment review of children with ASC and ADHD or LD. We've managed to maintain all our national targets despite the pandemic and the shifting balance of our staff availability. We have reduced our caseload. It's sitting at about 4,000, which is where it should be, or we like to try and keep it. When I say we've reduced it, what that really means is that we've managed to have a lot of throughput, where we're trying to work with people intensively so they have a beginning, a middle, and an end of treatment and are not sitting for months on wait lists not being seen. So the next slide, on slide 9, then gives a little bit of a breakdown about the type of presentation. So no surprises in here, but you can see the volume of children: emotional disorder, eating disorder, deliberate self-harm, conduct disorder, which is your kind of youth offending cohort, ASD, psychotic disorder, very low, which is as we would hope it to be, hyperkinetic disorder, which is your kind of ADHD profile, developmental disorders. And then we know that the highest proportion are females. The highest age group is around the 10 to 14-year-old age group. And in the main, the profile, the demographics are in the main around white British, which is probably more reflective of the demographics. There's some specific areas where the demographics look a bit different, but that would be in the main the population of patients coming through. And then the final slide here is around suicide, and just giving a bit of an overview of the very sad and unfortunate, thankfully very rare events. We have had, as you can see, 3 suicides by hanging in the last year. And again, we've given the kind of mental health conditions that have been associated with those. Now, a number of those cases are waiting to go to inquest. One has just been to inquest. The previous suicide last year has already been to inquest. Obviously, that's an extremely traumatic event, not only for families, but for our staff as well. What I would like to say is that as a foundation trust, we have very rigorous protocols around our serious investigations. We have an independent serious investigation team who do a full 60-day investigation into someone's treatment, right from the day of referral, right through to the event. Myself, I actually take those reports in person to sit with families to go through them, because it's very much about sharing any learning, identifying where there have been any gaps in service provision, looking at the whole overview, supporting the family. But we do have COVID permitting, we do sit down and have a face-to-face conversation with families around the outcomes of those investigations, which can be very tricky, I have to say, because without a sort of gross generalization in my answer, these things are never just a singular event. There is usually a complex, historic, systemic family situation attached to a lot of these. And then, we've not really seen any cases where this has been a one-off event that has resulted in death. There's usually a lot of complexity sitting in the background. Now, what we have been doing during COVID is, because we were quite concerned about children who have neurodevelopmental disorders, being quite isolated, etc., during COVID and not being at school. We've had to review some of the way that we do follow-ups from our crisis presentations. We've reviewed that particular profile of patients on the caseloads to make sure they're getting regular telephone contact and support, and they have our out of hours numbers, etc. And we've done a lot of work with our partnership with Mid and South Essex. Myself and a colleague are leading on a Mid and South Essex work stream with community peds, looking at the whole diagnostic pathway across Essex and any kind of lessons we can learn and models that we can implement from elsewhere. But I mean, obviously every suicide is absolutely tragic and devastating for all concerned. But I think if people would look at this in the last year in the context of over 4,500 patients at the start of the year, we've had 3 events. And you'll see there the slides 16, 17, 18, 19 and 2020, where we've looked at those across the several years. So do we know enough this year to say that suicides are much higher because of COVID? We certainly know that we've had 3 very tragic events this year. Can that be all attributed to COVID? That's a very difficult call to make. Okay, that's my quick whistle-stop tour, Councillor Rees. I'm not sure if people are we doing children's questions now? Are we doing adult mental health?
I'm going to open up for questions now, and then we'll go on to the joint presentation. Thank you very much, Jill. Very, very informative as usual. And thought-provoking, I have to say. I have Councillor Andy Wood first of all, and then followed by Councillor Harris. So Councillor Wood, please.
Thank you, Madam Chairman. Hello, Jill, and thank you for your report. It's good as usual. I like your reports. They are really good, so thank you on that.
Thank you.
I've got two things on the capacity and demand. I think you've probably talked it over to me, but we're at 14% on that for the 4 to 8 weeks when we was on 20% before. What you are doing to get that better? That's the first question. I'll go through the questions first. The other question is a bit concerned that you keep mentioning Mid and South Essex, and you do a report with them as well and send a shared report, but we don't have anything for, unless I'm wrong, it doesn't look as if North Essex has that same thing. And it's really good. I'm going to be sorting out, talking about suicide with the not the e-book anyway, but I think that's quite good with what you're doing on the suicides. It's a horrible thing to do, but I like the way you're working through that, so that's very good on that. So it's just those two, please.
Yeah. So, I mean, data is always a rather difficult thing to explain, and I'm always rather cautious about sharing it widely unless myself or colleagues are here to talk about it, because what it is it shows a snapshot in time of how things are working. But to try and explain it a little bit, and please stop me if this doesn't make sense.
Yeah.
When our service was commissioned, in order to put a few what's called stretch targets into the contract, what we were asked to do was break it down into how many children are you seeing in the 0 to 4 weeks, then 4 to 8 weeks, and then 8 weeks plus, because they wanted to see where people were in the pathway.
Yeah.
That bit that sits in the 4 to 8 weeks tends to be the bit that gets a bit squeezed, because if you're extremely unwell, you tend to be seen within those first 4 weeks with a lot of intensive input, be it in crisis, etc., etc. Then you maybe get a bit of a dip for children that are sitting with a kind of low risk when they're referred in. So they're maybe sitting, waiting between that 4 to 8. And once they get to that 8 weeks, then they tend to be quite a lot of activity in getting them seen. So it's just the way the measurement looks. The main thing for us is we definitely don't want to be seeing people sitting over 18 weeks. And we manage that extremely closely by doing what is called an exception report every month, so that all the managers and the assistant directors get a list of any patient that looks like they're sitting over 18 weeks. You'll occasionally get one person pop up and it says they've been on your caseload 52 weeks and not seen. 99.9% of times when our staff go in and look at that, before it ever gets shared with commissioners, it tends to be a data error, or indeed a complexity where you'll maybe have a family that have turned down an appointment 3 to 4 times, but because they're a looked after child or there's been a safeguarding issue, we won't close the case. But us trying to physically see them can be very different. We may, however, still be working with other elements of the service. There are some children as well that it can be very difficult to pin them down. I think the reason why the 0 to 4 weeks has really improved is because of COVID and the digital interventions. That being said, I know it's helped us be a lot more efficient, but I'm not sure our staff would want to just continue in a model where they only do digital interventions, because I'm sure my adult colleagues will cover this in their presentation, but we do need a bit of a mixture in mental health because it can be difficult. You know, you need a range of models, if you like. Now, the other bit, that's a really good point, Andy, about the Mid and South Essex footprint. The reason I'm raising that, because there's lots of fantastic work going on in North East Essex and West Essex. They sit in a slightly different STP footprint. What I was trying to highlight to colleagues on the HOS today is the work that's going on very robustly across the Mid and South Essex footprint, which is one STP. But I know up in West, we've done loads of work with our Hertfordshire colleagues. We're doing a piece of work up there at Princess Alexandra around crisis presentations. Up in North Essex, we've got lots and lots of different streams of work going on there. That's where we're doing the joint seconded post across health and social care. So yeah, apologies if it sounded that it was focused on Mid and South Essex, but I guess that's the audience we have today, but we do have other STP footprint work streams going on as well. Does that cover it?
Yeah, no, thank you, Jill. Can I just ask for one question, Jill? It's a quick one. This North East Essex that you're doing, is there any chance you could keep me updated on what you're doing in North Essex so that I can, you know, and if I can help you in any way, I definitely will. But if you can get me updated, please.
Yeah, we actually just literally last week signed off a job description with a colleague in social care.
Yeah.
Sue or Lizzie might be able to update as well, because I think they're doing a very similar thing as part of this work stream, because I know EPID are involved as well, where we're trying to have a whole sort of multidisciplinary foliage range model with a seconded post. And we signed that off last week, so that should be good to go.
Brilliant. Thank you very much. Thank you, Jill.
Thank you. Councillor Harris.
Yes, thank you very much, Chairman. And thank you, Jill, for the presentation. Very good. I've just drawn together my questions over 2 or 3 of your slides, and linking a couple of slides, you talk about collaborative working, which I understood, and you very eloquently explained some of that. But that collaboration, is that working with schools and other agencies? Because in another one of your slides, as I said, I was linking a couple of your slides, the highest volume are in the 10 to 14 year age group. Are you working with schools, school head teachers? Because I'm a school governor, and yesterday I heard from 2 head teachers that they're very concerned over some of their pupils. And I just wonder whether that collaboration, how far it reaches, how far that goes out, and how many people you're getting support in the work that your good team do.
Yeah. So thank you, Councillor Harris. I mean, it's always a really, really challenging area around the schools. We have, 600 plus schools across Mid and South Essex. We work really proactively with all our digital offers, our single point of access. We continue to promote that to schools. In fact, during COVID, as we came out of the first phase of COVID, we did a mass comms kind of communication. Some of our Essex County Council colleagues were involved in that, where we again did a bit of a, hello, we're all here, we're all still working, mental health services have not closed down. It was just to keep getting the message out there. Now, the other thing is, I really do think there's been quite a lot of heightened anxiety once children went back to school after the summer. So you've got a bit of a perfect storm, don't we? Because we've got lots of adults, parents and families extremely anxious. I mean, I've certainly spoken to colleagues and friends of mine who definitely didn't want their children to go back to school for fear of COVID. So you've got a bit of anxiety there naturally in our population anyway. Then you've got children going back to school who haven't been there for a long time. We've got all the anxieties around the educational, let's say, gaps over the year where people were not at school for periods of time, etc. There is a bit of a perfect storm there around anxiety. And actually, yesterday I was on a summit to do with inpatients across the southeast of England. And what they talked about was that mental health services for children are becoming a bit of a repository for anxiety, so that anyone that has any element of anxiety, not only do they get to get referred to mental health services correctly, if that's the right place at that time, but also that with the kind of escalation of a lot of that post-COVID, that there's a real push to try and admit people into tier 4 beds. Sometimes that is absolutely not the right place. Now, what we've been doing really hard with the Mental Health in Schools programme that I talked about earlier, Essex has been really successful in getting 7 teams funded by NHS England. All of those staff are employed by us at NELFT. Some of them are in their intensive training. And then there is a range of schools that have signed up to that Mental Health in Schools work stream. The schools themselves had to nominate themselves via our commissioners. And then those, I think it's 56 staff, actually work primarily within the school environment. So they're physically situated in the schools. Now, I know our commissioners, Helen Farmer led on this, and they worked really, really hard with all our schools to try and get them to sign up, but it was a voluntary thing. But I can only see that particular work stream continuing to develop. Now, myself, Helen, and a few colleagues actually wrote those bids to get the funding. So we will be taking every opportunity for any other piece of funding availability to embed that. It would be lovely to have that in every school in Essex. And I do think over the next few years, we'll really see the impact of that, because that's about early intervention, brief intervention, and you're physically on site working with the teachers. Part of the work stream as well, I think, has really got to be focused in the future on supporting the actual teachers and their understanding of, you know, as they would say, they don't know what's normal in the anxiety range coming up to exam time, for example, and what's something that absolutely requires a referral or an intervention. Yeah.
Thank you, Chair. Just coming back on that, the other question I had was over your staff and the virtual interview that you're doing. So obviously, virtually, you can actually, I'm guessing your staff are very professional. They can see attitude, behaviour, words, expressions, etc. What they can't see, perhaps, is the more safeguarding issue like self-harm evidence, you know, things that are off camera, as it were. How do they determine that? I know they're very professional, but how do they tease underneath that gap where they look for things that are not immediately apparent?
And I think that's absolutely correct. And that's why I think I said earlier today, you can't just move to an all digital model. Much as I'm sure some people might like that, that's not going to cut it in the long term. I think particularly, and I was on an escalation call this morning before I joined here to do with a family, happens to be in the Chelmsford area, whereby there's been a lot of intervention between social care and health with the child. But actually staff are going out to do home visit today because they really think that the mum herself, they think, has undiagnosed mental health problems. She can't cope and manage, and trying to kind of judge a lot of that digitally really doesn't cut it. So that's where I think it does take a bit of careful judgment as to perhaps someone that's doing well in treatment. They do get collaborative information from families, etc., when they do the digital calls. And I know any of the higher risk patients, there's always a slot given to talk to mum, dad, or the school. But again, staff were quite concerned earlier on this year because obviously children weren't at school. So you didn't have that collaboration and corroborative information that we normally would have. That's why we also have our crisis teams that have a 4-hour turnaround. And I think, picking up on your point, Councillor Harris, I do think part of that is why our crisis team have had over 200 referrals per month in the last couple of months, because a lot of those things have escalated quickly because of family issues. You know, a lot of people, for some of us, I'm sure it's been nice to have family time at home, but I think I said this last time, for a lot of families, all being locked in together is not a mentally healthy place to be. I definitely felt that myself a few times in my own house anyway.
I was the reverse, but I love spending time with the wife. But Jill, just a question for Richard and the chair, really. Is there a reason why the slides weren't entered on the screen? Because I was able to follow on my other laptop, but of course, the viewer at home on YouTube and people looking at this meeting afterwards won't have seen those slides. Is there any reason why they weren't presented?
No, we submitted the slides for presentation a good while ago, so apologies if I'd have known that. I could have shared them today, but Councillor Reeves, can we make sure that everybody's got a copy of those that requires them, because we were asked to submit them for that reason, so no problem at all.
We all have copies here, but I'm not sure about the situation on the broadcast. Richard, over to you.
It was the viewer at home, probably, Jill. I was talking about the people who are viewing this after the event.
Yes, I realise that. Yeah.
Okay.
So if for people at home, if they the only way they can really access the link for the meeting is through the website. So the agenda pack's on the website, so they'll get it both from there, so they can follow it at the same time.
Could we the next presentation share the slides? Is that okay?
Yeah, no problem. No problem.
Thank you.
Thank you very much, Chair. Thank you.
Right, thank you. I have two more councillors, and then I won't take any more questions. We'll move on after this. Councillor Baker and then Councillor Edwards. So Councillor Baker first, please.
Thank you, Madam Chairman. And thank you, Jill, for the very detailed presentation. certainly very interesting, but so worrying. And we are talking about the most vulnerable children in Essex, children excluded from school, children not attending school, children who are looked after. You referred to these, children in care where the care is broken down, children with a whole range of learning difficulties, autistic spectrum disorders, attention deficit disorders, emotional and behavioural difficulties. So many children, very, very vulnerable. And this has been going on for a long time now. The children are attending school, but we know, you know, I know that there are an awful lot of children not attending school or being excluded from school. You've partly covered my question, because I wanted to link in with the closeness that you're working with the education services. You mentioned about working closely with schools, and I'm fully aware of this. I know the relationship is very close with individual schools, with individual children. But my question is taking it broader than that, if I may. And are you working closely now with the education services? Because the education services, of course, are have direct links with all schools, mainly county schools, of course, but academies as well. They have this overall view, and I think a closer working relationship with the local authority, like with the director of the education services, with social services, all part of, you know, the Essex service, if you like. Is there a very close collaboration there? That's the first part of my question. The second one is, I do consider that 35%, I won't call it a treatment target, but I find that figure so worrying when it comes to very vulnerable children. The waiting time, anything can happen during that time. If I can just touch on the suicides that you mentioned, you know, 3 awful, sad cases that you've mentioned. If I can say I'm aware of another one, and I hadn't mentioned this before, and it wasn't in connection with hanging, actually, so I don't know whether there's been an inquest, or do you have any sort of figures that are of children who have died where there is a possibility, sadly, of suicide, where you don't have the outcome. But it's mainly about the education. But I would appreciate some feedback on children who very sadly lost their life through suicide. Thank you.
Thank you, Councillor Baker. So just to pick up on the question around education, I mean, it's a very fine balance, isn't it? Because as a mental health provider of children who require a medical intervention, our primary focus has to be on providing treatment. That being said, we do have a responsibility to work very closely as part of a system, yeah? And we do link very closely with our education colleagues. In fact, in the last 2 years, we actually we have 7 sessions per week, no, 7 people, which is more than 5 days, if you like, 7 educational psychologists who work with us, who are on like seconded posts. So that's to kind of improve the whole link between mental health, educational psychology roles within schools, which, to be fair, have changed, I think, quite a bit over many years. But the Mental Health in Schools project that I talked about earlier is, I think, something that's been funded nationally for the areas that have been lucky enough to get the funding. And they are trying to do a whole England-wide coverage over the next couple of years of those projects, all funded centrally by NHS England and Health Education England. That's to fill a bit of the gap, I think, that you're referring to, because we can't have education sitting over here and health over here. But that being said, remember, our primary focus has got to be on mental health treatment. So whilst we do have a role in supporting the schools, that's not our primary function. We've got to work with. What we should be doing as a system is enabling and empowering our education colleagues to be able to manage things in a different way as well. Now, I have a personal friend who happens to work in a school in Essex herself, and she heads up that, you know, the kind of work, not pastoral care, but children are more challenging, difficult, excluded. I mean, what she refers to me is that, and I'm sure I've said this on this house before, anytime we meet up and talk, you know, maybe talk about work, she'd be saying they have an absolute tsunami of issues within the schools: poverty, social issues, family and systemic issues. All those things in time then translate into children presenting with anxiety, low level self injurious behavior, a lot of these crises, running away, going to A&E. There's not like one single fix out there, and it's very difficult to transport yourself into someone's family and try and treat what has probably been 3 to 4 generations of problems. We did have a situation in Essex last year, and this is the type of, you know, just to give a bit of anecdotal context. We had one family who took a child to Colchester A&E, just left them there, rang us and said, I'm not having them home. I don't want them back. We can't cope. But, and I know this is difficult, but our staff have had to work with that family and social care to say, you have to take them home. It is your child, and there is the parental responsibility here. So we do, I think there's quite an interesting discussion goes on nationally around a lot of the family systemic issues that present. But we have to enable families to be able to manage those, because they're the people with parental responsibility, unless, of course, Essex County Council, Thurrock or Southend become the corporate
Yes.
parent.
Yeah. You give me a bit of feedback on any young people who have lost their lives, where the inquest hasn't been held yet. Have you any information?
So as I've put on the slides there, I mean, I'm obviously very familiar with the minutiae detail of all of those cases, as you would expect me to be. I know for a fact in the 3 cases that are on the information today that all of those cases we had quite a lot of involvement with. There was a lot of complex situations in the background. One of the cases had a complex autism presentation with impulsive behavior. You know, it's not just one thing, it's just an extremely sad event. And particularly in children where there's a lot of impulsivity. Not in the cases I've presented today, but I have been to inquests and I've been part of serious investigation discussions where 2 suicides that I was involved with elsewhere. The police, obviously, at the time of the inquest, what we know was that those children had been on social media late at night, had an argument with a boyfriend or a girlfriend, and then completed an act of suicide. So there's lots of other catalysts in there. Yeah.
It's
Very
extremely
difficult.
sad.
Very
I
sad.
mean, extremely sad. Is there any possibility, Jill? Sorry, this is, and it's linked in with this 35%, because the time lag I do find actually. Some colleagues are aware that I'm a former special head teacher, and I know professionally that support needs for these children and families needs to be pretty quick, otherwise there can be a massive deterioration. So is there any way that that figure of 35%, the time frame, could be, or resources could be directed more to this very vulnerable group? I mean, I know that means that others may lose out, but we are talking about, you know, a very vulnerable group of children here.
Sorry, just explain to me, sorry, Councillor Baker, I'm not sure of the question. I think what I was talking about was nationally, children's health services are funded to see approximately 35% of the population. And I think I always start by saying at these meetings, do I think that it's right that people wait to be seen? No. Do I think it's right that elderly people wait 2 years for a hip replacement? No, I don't. Do I think it's right that people wait for cancer treatment? No. But we have to manage within the confines of what we all have the finances to do and provide. And nationally, the funding for children's mental health services is with an ambition to meet about 35% of the need. Now, that doesn't mean that the other 65% of people are there hammering down the doors. What we don't have is a lot of unmet need, i.e., I never see complaints from people saying, I've tried to get referred and I can't get in. Because we've got the open front door, what I'm showing today is that we're having an increase of volume of people coming in, and we're at that 35%. Some areas of the country, their access targets are probably down at 20% because they don't have that open access front door. So there's a lot more hurdles to get through to get into the service. Some areas of the country, I know up around Manchester, Birmingham, if you have a child with autism or ADHD, the waiting lists are closed because they're 3, 4, 5 years long. Now, we're not the commissioned diagnose or provider for diagnosing autism and ADHD, but we do get a lot of those children by default because they've got significant behavioural challenges and problems. And if there were one plea that I think we need to move to its speed as a system, not just in Essex, but everywhere else, is a much more robust pathway and offer for children who have a neurodevelopmental condition. Very often we absolutely perseverate on getting someone a diagnosis, and the family think that that's going to be the cure to everything. The diagnosis makes no difference, except it might help someone, as you would know, Councillor Baker, with an education and healthcare plan, but it does not assist a family to manage that child.
Yeah, and I think I was really thinking about the acknowledged increase in mental health conditions amongst the population, certainly amongst children. 10%, I think that's a figure that the National Health Service is saying that there's been an increase. So basically, I think you've covered the points actually, Jill. And I can see that it's a huge task. So perhaps I won't push it any further at this stage because I can see that there's an awful lot being done. And thank you so much for all you're doing and your colleagues. That's very obvious to me.
Thank you.
Okay.
Thank you, Councillor Baker. Thank you, Jill. Finally got Tony Edwards. Those members who haven't looked at my chat box, please refer to it. Thank you very much indeed. Councillor Edwards.
Yeah, I'm trying to unmute. I'm sorry. I've just got two questions. One, you spoke about the percentage of the 20%, if I remember rightly, of bank staff, and what does that percentage have any, or are there any concentrations within that 20% that would have implications for the efficacy of the service? So, you know, where are those 20% concentrated, and does that have any, as I say, implications? My second question relates to, you spoke about wanting to ensure that there is throughput, that cases have beginnings, middles, ends, etc., and are dealt with in a focused way. But have you got any evidence at all of repeat referrals, whereby, yes, you very much focus on the beginning, the middle, and the end, and getting them in and out of the system, but then subsequently, are you then seeing any of those that you've been dealt with then coming back subsequently, and on what have you got any sort of notions in terms of percentages of the numbers that are requesting to come back into the service? Thank you.
Thank you. Really good questions, Councillor Edwards. So the 20%, interestingly, yes, we do know the areas where we have higher rates of vacancies, and that tended to be in our crisis teams. As you can imagine, crisis work is not for everyone. It's 24/7. Our teams work all through the night. So that can be, and it is again around Greater London, Essex, Kent, quite a challenge to recruit people to those posts. What we have done in the last couple of years is amended the model that we're running and put a few more senior staff in there. In fact, what we actually did with our crisis team was to recruit some permanent staff at a much higher bands who are like psychotherapists and family systemic practitioners to address some of the stuff that I've talked about earlier, where you tend to get a lot of the young people in crisis, but it's a really complicated family situation. We then work with them intensively for 6 to 8 weeks before they go back to their kind of normal community team. So we do monitor those variances on a monthly basis in relation to the workforce vacancies. What I am pleased to say is in the areas where we use agency staff more, we've got a lot of very long-term agency staff who are, if you like, nearly like permanent staff. But unfortunately, in the kind of healthcare economy and market, agency work is very attractive for some people. They pick and choose when they want to work. They don't have an NHS pension and NHS holidays, so they tend to get paid a lot more. And I mean, that's a bit of a balance for everybody. We used to have a very similar problem with medics across Essex, where we had a really high level of locum consultant psychiatrists. I'm pleased to say we've managed to recruit a lot more permanent people, and that's not such a challenge. But we do monitor that workforce vacancy very closely and our turnover rate. That being said, I know it doesn't sound amazing on this call, but it's a lot. It's down from about 27% a number of years ago, probably about 4 or 5 years ago. So remember that the vacancy rate also is reflective of the fact that in the last couple of years, we've had additional funding to increase our crisis team, increase our learning disability team, increase our SPA team. So you're getting more money to embellish the service, but actually the vacancy rate hasn't gone up. So that means there is attraction to permanent posts, if that makes sense. And then the second part of the question you asked was around throughput and repeat referrals or re-referrals, as we call them. The throughput issue is something that's clinically really important, because what you don't want is children languishing within children's mental health services when they don't need to be, because it's really important to get treatment and give people and families the skills to manage things and help them to move on and normalize that, as opposed to being labeled and maintained in mental health services for many, many years. That being said, we monitor every month the amount of re-referrals, which are usually quite low. I don't have data presented on that today, but children who tend to be the more complex, looked after, etc., don't tend to be the children where you get throughput. They tend to remain open for a long time on the caseload, because obviously the risks are high, so they don't tend to get discharged. Does that make sense?
Yeah, I suppose what I was trying to get through is the success or otherwise of your model.
Yeah. Well, I think it's not necessarily just our model, but it's about what nice concordant evidence is, what the National Institute of Clinical Excellence
of the model, let's put it that way.
Yeah. Yeah, and what evidence shows us is that there are very often no benefits to keeping children and young people in treatment for a year. That is no more effective than them being in treatment for 3, 4, 5, 6 months with targeted interventions. So we very much in our pathway model, all the treatments that we offer are nice concordant treatments. So if they're not approved treatments, we shouldn't be offering those. Very often families will go and research things on the internet and come back and say, I want my child to have this because someone's told them or they've read it. But if that's not evidence-based approved treatment, that's not an intervention that we offer.
Thank you.
Thank you.
Thank you, Councillor Edwards. Thank you, Jill. Two very quick questions from me. Right at the beginning of your presentation, you mentioned you had a number of unknowns presenting. Presumably these have come through from a GP referral, do they?
Most of the unknowns turn up at A&E after self-harming.
Right.
Yeah, not GP referrals usually. I mean,
Right.
I'm sure there's maybe the odd one, but in the main, what we did see in this second episode of the pandemic was children we'd never seen or heard of before, hadn't been referred, no history of any presentations or complexity, and turning up in crisis at A&E. But I guess you get the whole reason there. You get, I've fallen out with my family, I've superficially lacerated my wrist because I've fallen out with my boyfriend. I had a huge row with my boyfriend and I've taken 14 paracetamol. It goes from that to people that have taken extremely significant overdoses. I guess people it's hard for us to kind of calibrate, isn't it? Because when we hear that a child is presented to A&E in crisis, we immediately think it's extremely serious. And very often it's not that.
Right. Thank you for that. And my final one is, with you and your colleagues, do any of you ever need counselling? Because I mean, you're going through very tough times. You know, what happens with because you know, you're hearing so many, you know, dire situations that you have to cope with. Does counselling for you and your staff ever crop up?
So for myself personally, no. I mean, I've worked in mental health fields, adults and children, for many, many years now, and I'm sure you probably develop a certain amount of personal and professional resilience. That being said, I do think COVID's been a challenging year for everyone. The impact of COVID, the amount of work, and a lot of us probably haven't taken a lot of leave this year. What we have noticed, particularly around the suicides and self-harming, we've put together a bit of a kind of psychological therapeutic group, if you like, for staff, where when we do the debriefings around suicide, we do offer one-to-one support. We've obviously got occupational health, because I do think we underestimate the impact and the trauma on clinicians involved with some of those cases. And even if the work that we've given the child is gold standard, there's always lessons to be learned. There are always gaps in these things we could have done differently. However, even when the care is gold standard, you can imagine the anger from families lash out, they want someone to blame. And we have really seen quite a lot of that impact on staff. I mean, there was a suicide in East Essex not so long ago there, and we do have a staff member on long-term sick leave because she'd worked with that child for 4 years.
Yeah. Right. Well, thank you very much, Jill. You know, very, very, very interesting presentation. And we've got 3 people who've been very patiently waiting in the background. We must push on. Sue Waterhouse, Eugene Staunton, and Peter Whiteman, adult mental health care. So could I please open the floor to you? Thank you.
Thank you very much, Chair. Richard, are you going to share this presentation?
I'm just about to do that right now.
Perfect. So, Chair, I also have with me Lizzie Wells, who's my counterpart. We are the 2 directors of Essex Partnership Trust, and we're going to do the initial part of this presentation, and then we're going to hand over to Eugene and Lizzie, and then Jane Intengata from Mid and South. Unfortunately, Peter Whiteman has had to leave, but Lizzie can do the West Essex. So thank you very much for inviting us back here again. We deliberately decided, because as you're aware, Essex is split into 3 STP areas. So Lizzie is the Director of Mental Health for 2 STP areas. I'm the Director of Mental Health for Mid and South Essex, so 1 STP area. And we decided that it'd be better if we coordinated this time, because I think last time the presentation was a little bit repetitive and wasn't well coordinated. So this time we've decided to try and put it onto one presentation. So if you could take to the next slide, please. So initially, I'd just like to update you. Last time we talked you through our response within EPIRT to the pandemic. And so today we just wanted to update you. Again, we continue with the emergency planning, the tactical command reaction to the pandemic that we spoke about last time. We had stepped it down at one point recently, but with the second wave coming through, we've stepped it back up again, and we are meeting daily with bronze, silver, and gold command. And we will just keep on with that, responding to whatever wave or whatever response is needed. We continue with our focus on vulnerable patients, and staff will visit patients. We work virtually wherever possible, but where we've identified that there's particular risk with people that we work with, we will see them face to face, or if we're working with them virtually, we will increase the amount of input that we give those individuals, and each team holds a risk register of our vulnerable patients, both from a physical health perspective and a mental health perspective, and we will respond according to their need. As I've just said, digital consultation continue. It's meant that we can reach people further afield, but we also need to be mindful of those people that aren't able to access digital consultations, that don't have the technology. Then we will find a way around that. We've also, it is interesting, Chair, that you just asked a question about staff wellbeing. So during the pandemic, EPUT stepped up very quickly a wellbeing staff support service that spanned the whole of Essex for not just mental health staff, but for all physical health staff into our acute trust, local authority, care homes. We even provided support to undertakers. And it's been recognised nationally that there's a need for this to continue, and there's been some funding that's been sent down nationally, which we work together across the 3 systems, and actually with our partner agencies in Hertfordshire and Suffolk. And we put in a successful bid and have received funding to expand our staff wellbeing service to go on further than the current months. What we're expecting is that there will be a need for this kind of service for up to 3 to 5 years post the pandemic. And what we've been able to do by having increased funding is extend the offer that we have to go into the acute trust, because people particularly traumatized are those people working in ITU, for example, who might not be particularly psychologically aware of the impact on themselves. So we are working at setting that up across those 3 systems to be able to provide a really comprehensive offer, increasing the psychological awareness across all of our parties, but into social care, care homes, etc. So that's quite an extensive piece of work. We also implemented the A&E diversions across our 5 acute trusts. Much of this continues. The only ones is actually since since we sent this presentation off, is Basildon and Southend have both ceased theirs, purely because they need the space that we'd moved into for alternative services. So we're back in ED there. And a big piece of work during our last pandemic was to implement across the trust, across the 3 STP areas, the crisis response 24/7, which is accessible via the 111 and has a direct access for professionals. So we started that in April, beginning of April. I think it was the end of March for the North, East and West, but beginning of April for Mid and South Essex. And that continues to bed down, and we're seeing a significant increase in demand. If you could move to the next slide. Could you move to the next slide? Oh, thank you. So the impact on our workforce, we shared this with you last time, and the current presentation remains much the same. This is up until August. We found that staff sickness as a result of COVID to be fairly low. We've had 1 or 2 little spikes where through the track and trace people have had to isolate, but that have been able to continue to work, but on a virtual basis. We do find that 1 or 2 staff are not able to work, and we've just had new shielding letters out for some of our staff. One of the things that we are beginning to do is the twice weekly testing for all patient-facing staff. So the initial response will be that they need to be observed in a bit like a pregnancy test approach to testing, that the first one they're observed, and then from then onwards they will carry out their own testing on a twice weekly basis. So we're just beginning to roll that out now. I'm going to pass you over to Lizzie now. So next slide. Lizzie, if you're still there.
Sorry, I was just turning my mute off. Good afternoon all, I'm Lizzie Wells, Director of Mental Health for North East and West Essex. So yes, moving on to map an increase in demand. So we needed to understand the demand for services had the pandemic not struck, and people might need more support due to deterioration of their mental health during the pandemic. New demand is driven by people needing support due to the wider impact of pandemic. So this is some national data that has been pulled. It's not just Essex, but as you can see, it's broken down into population group and also mental health condition. So that's the impact that we are looking at in terms of the increase, the proposed increase. Next slide, thank you. So locally, we forecast that the mental health surge in the next 6 months could be as high as 10%. There's no national forecast yet, and the surge could be higher. And later on in my presentation, you'll see some data that's relevant to the North East. And I think we are going to see that in terms of different systems and different demographics, that the surge could be higher in certain areas. We with other mental health organisations are beginning to identify that the mental health surge includes a cohort of patients that are new to the service, which is what Jill Burns talked about. So I think that's across the ages, that obviously, you know, the pandemic has been very stressful for us all. And it obviously depends in terms of what your support network looks like in terms of how you may respond to it. However, we believe that through technology and improved bed management and our new crisis services and A&E diversion services that are across all the systems and working in an integrated way, again, not just with West Essex, but the whole system, we hope that we can mitigate a potential second surge of up to 10%. And I think we touched on this last time we met in September, that we're in a very fortunate time that mental health services are receiving funding via the 10-year plan. Those funding streams are coming down. However, it's an extraordinary time to transform services, and I think there needs to be a lot of praise for all of our services and the leadership in relation to implementing new services during the pandemic. And I'll talk about the crisis team in a little bit. So the Trust aims to maintain 85% occupancy in our beds, in our units, to support social distancing on the ward. And we recognise that this is a challenge at the current level of demand. So that's the tension. We've got increased demand, but we're also trying to ensure that we abide to infection control regulations, and that people are safe, that they're safe due to their mental health presentations and the risk that can pose, but that they are also physically safe and that we are COVID free. Touch wood, at the moment, there's really good management across all of our wards, and we have very few people that are tested positive. So I think that evidence is that we do have good infection control. Thank you. So I'm going to hand over to my colleague, Eugene Staunton. If you'd like to introduce yourself, Eugene.
Thanks very much, Lizzie, and good morning, everybody. I won't turn my video on just because I've got some bandwidth issues. Hopefully everyone can hear me. I'm Eugene Staunton. I'm the Deputy Director of Mental Health Transformation at North East Essex CCG. So I work closely with Lizzie and her team. Just some of the key messages from a CCG perspective. Our next phase of recovery planning is expected just before Christmas in terms of further guidance and priority areas to be looking at across the NHS. So we'll need to respond to that. We've had 3 phases of recovering over the course of the last 9 months or so to see us through the COVID period. We have been focusing, as with our other NHS services, of getting services back to business as usual where that is possible, particularly with our elective services and indeed with our mental health services too. You may have heard of the Mental Health Investment Standard, which is something that we are audited as mental health commissioners within the NHS, which effectively means that there needs to be parity with investment that goes into other parts of the NHS. Mental health has traditionally been underinvested in. So this is just a statement to say we are absolutely fully committed to meeting those mental health investment standards to make sure that we get the service transformation that is required. There has been a local conversation going on, a recent conversation about our out-of-area placements, which continues to be a national challenge for mental health providers and CCGs, and increased acuity of presentations that are coming through our mental health trusts. So we are
Eugene, just you are a little bit in and out on the sound. Councillor Woods has just raised that. Sorry, I don't know if you just to mention.
Sorry, I beg your pardon.
Better.
Thank you. So in terms of our out of area placements, that is an area of focus and concern for us. So we are looking at some additional commissioning that might be required to bolster our local capacity over the winter period, with CCGs working together with ePuts at the moment. Both Lizzie and Sue have mentioned the rollout of the 111+2 service, which was fully invested in, which has really helped those individuals who are in crisis and requiring that additional support. CCGs have worked across Essex as a county to commission a specialist perinatal service. So again, a real cohort of need requiring support, particularly through this difficult time. North East Essex CCG has recently commissioned an adult ADHD service, which is due to go live 1st of April next year, again, which was seen as a commissioning gap. And we've additionally commissioned a personality disorder and complex needs service for North East Essex, again, recognising that particular need. Looking forward, ePuts will be taking on the IAP service, which is currently provided by Hearts and Parts, with a real opportunity to build that into our community models and working very closely with our primary care networks going forward. But have the next slide, please, Richard. Thank you. Sue has mentioned the support that's gone into providing, as required, to our frontline health and care staff. And I should mention that in the last week, a £50 million pot of funding has been made available to all ICS areas. For our Suffolk and North East Essex area, that's £750,000. And we've started a conversation with ePuts, Essex County Council, VCSE partners, about how we can particularly support our patient flow through our mental health services coming into the winter. So that's something which will really help us with. Just in terms of suicide, I won't go into because it's further down the agenda this morning, but there are particular challenges that are being thrown up which we need to respond to. Long COVID, you will have heard of early in the stages of understanding the real need and demand that will be bringing with us in the future, and an increase in prescription of antidepressants is something that we've witnessed as a CCG working with primary care. I'll pause there and I'll let my Mid-Essex colleague come in for the next slide, I believe.
Thank you. Okay, thanks very much, Eugene. So I, as Sue said at the beginning, we don't want to repeat across each system because we are rolling out the same services across Essex. For North East, I wanted to focus on the Crisis 24/7 service. I've just completed a 6-month evaluation. We launched on the 31st of March, right at the beginning of the pandemic. And, you know, it's been a fantastic service. And what the audit has shown is that we are what we call high fidelity. The audit is a university, a UCL, a University Central London, City of London audit, and we have come out as really high fidelity. So that's great, and that's about how we practice in terms of accepting referrals 24/7, being able to complete an assessment in the community 24/7, having intensive home treatment, having psychological input. So there's 39 standards that we mapped the service against, and I think to achieve high fidelity during the pandemic is fantastic. So this was just some data that we pulled, which I think just gives a bit of a story. I know last time some data was asked for in relation to the increase in demand due to COVID. And as you can see, we've mapped against 2019. I think that's actually on the next slide. So this is the data from the Crisis 24/17, which just started this year. And as you can see, that there are high levels of 111 calls every month. So looking at August and September and July going back, we actually saw an increase, and I think that was as people came out of lockdown. So you can see when the service first started in at the beginning of April, that it's more or less doubled really into September. Okay, so if we go on to the next slide. So this is the A&E data, and I just wanted to show this as a contrast. So as you could see for September with the crisis calls, there was 800 people that phoned who were in a mental health crisis, and the A&E attendance is only 148. 138 in September. Now it's up from last year at 116, but if it wasn't for the Crisis 24/7 service, the A&E departments would be inundated with people who are in a mental health crisis and needed support. So I think the decision to transform and implement this new service at the beginning of the pandemic was definitely the right decision, and has really supported and taken that pressure away from the emergency departments. Okay, next slide, thank you. I think there's one more if you just go back, Richard, sorry. That's it, yeah. So this is the home treatment. So the crisis team, just as a quick overview, you can dial 111, press 2 for mental health. You then go through to receive some telephone support and advice. If it's deemed that you need actual triage and assessment, you're then referred through to a senior clinician who can complete that, who will then decide whether you need an urgent assessment within 24 hours or whether you actually need an emergency response within 4 hours. The team also, as you could see on the first slide, receive calls from GP, from ambulance, and the police, but the majority actually are self-referrals. So it's doing what it was meant to be. It is about people phoning up and feeling that they can access a service and be direct through to mental health without having to go via their GP. So I think that really has impacted on A&E attendance. So home treatment are the other part of the team. So following that initial crisis assessment, the home treatment team provide intensive community support with the aim of keeping people out of inpatient units, out of hospital beds, and providing them and their family and carers with that intensive support at home. So as you can see here, really good, again, response, and the majority is face-to-face work. So the crisis and the home treatment team have continued to see people face-to-face, because I think, as Jill alluded to earlier, virtual isn't for everyone, and I think in terms of a pure, a mental health crisis, it's really important that we actually engage with that person physically and have a look at what's going on in their home, and a home assessment and a support network, which is really difficult to do over a camera. So there is some telephone work when it's appropriate, and it might be that somebody has a community visit during the day and then they have a telephone call later on to follow up to check that they're okay. And also some, people of all ages do prefer to have a virtual call, but the majority has been face-to-face work. Thank you. So I'll hand over back to Sue and Jane to discuss Mid and South. Thank you.
So Jane, would you like to introduce yourself, and Jane will take us through this next bit.
Thank you. My name is Jane Athangata. I'm the Associate Director of Mental Health Commissioning for Mid and South Essex, and I also lead on the Urgent and Emergency Care Mental Health Transformation on behalf of the 5 CCGs. Just to kind of close that loop on the upstream side of things, what I wanted to add around the 24/7 crisis services, we've also got in Mid and South Essex, we've commissioned 3 sanctuaries that are run by the voluntary sector to support the clinical pathway, and it's a joint kind of partnership between the 3 voluntary sector organizations and EPUT. And this actually supports people who don't necessarily require a clinical intervention, but are in a crisis nonetheless, and need to be supported in a very, very different, in a way that does not require medical intervention. So I just wanted to add that as part of the 247 crisis service offer. Now, the crisis service is all upstream. So on downstream side, we are also developing our integrated primary and community care support, so that we have a balance in the system, because for a very long time, I think there's been heavy utilization of the more specialized side of the mental health pathway, as opposed to looking at kind of like evening it out, supporting people a little bit earlier, so as the symptoms did not require that very specialized kind of like support. And one of the things colleagues have mentioned earlier on is that we've received a significant amount of investment over the last few years, and this continues again up to 23, 24. And part of that is to look at how we are going to review what our community mental health service offer needs to look like. We're going to review also what that looks like interfacing with the developing primary care networks in each of the areas. So in Mid and South Essex, we have developed the model that we feel would be best implemented to support not just the GPs, to support people, in primary care and support them to stay in primary care without necessarily requiring them to step up into secondary care, but also to look at how people who are stepping down from secondary care are better supported in primary care to ensure that there's that seamlessness between the two, but most importantly, that we're wrapping packages of care around people to help them maintain the best way they can within community services, and be able to be supported more widely for other needs, not just necessarily from a clinical perspective, to ensure that they don't relapse into crisis or requiring additional support in more specialized services. So from a Mid and South Essex perspective, we've got 28 PCNs, and we're starting to phase in this new model of care which has been developed. It has been co-produced with clinicians, with commissioners, with service users and their families and carers, and voluntary sector support and social care, of course. And now we're moving towards implementing it in a phased manner across Mid and South Essex, based on the respective networks that we've got. But if each and every area will eventually get an integrated team that works in primary care to support GPs and primary care in general around mental health, there will be that managing of the interface between primary care and secondary care, and interfacing also with the crisis pathway. So as people who are stepping down from the crisis pathway are supported either within secondary care, or they're supported actually to manage better within primary care. And then we'll also be looking at what complex care needs to look like. So we're not talking about eating disorders, but we're talking about early intervention in psychosis services, and how we move away from CPA. All that will be managed in this new model of care, and we are going to be facing in the development of each and every bit of that pathway together in a co-produced way. So that diagram you're practically seeing is just kind of like a representation of what I've just talked about around this new model, where it's going to be, very, very patient-centered or person-centered, and having care wrapped around people, so that people are they're able to support to access care based on their needs. It's going to be very much so needs-based, and it won't be a situation where it is about people trying to fit needs into services. If anything, it's going to be now the other way around, and it's going to integrate health and social care, primary and secondary care, and it's also going to be looking at how we integrate physical health and mental health, so that we're giving that holistic approach to how we support people. Eventually, by the time the model is fully implemented, it will help us balance out the system, so that we're now no longer heavily dependent on the inpatient side of things. We are no longer heavily dependent on very specialized care, and we're supporting people a lot earlier before their symptoms have escalated. Of course, for this to work we will need, of course, to work with our local authority colleagues to enable us get that kind of flow within the system, because there are a lot of people who are presenting with needs actually that are not so much on the medical side of things, as Jill said earlier on. They're more really social. So we will need support really from local authority colleagues to be able to actually implement this. Next slide, please. I just wanted to touch very lightly on IAPT because I know Eugene has talked a little bit more on IAPT services. In Mid and South Essex, we've got our 4 providers, and they're all now working very closely together to share learning and also to understand how we manage to support each other in the system, especially in view of the fact that we are now anticipating a surge in demand, as everybody else has said earlier on. We have already seen that surge, especially in the southeast part of the system, where there are more people who are presenting, and the acuity also of people presenting even to the IAPT services is slightly higher than it was pre-COVID. The other thing also we are doing is how the IAPT services are going to be part and parcel of supporting the long COVID or COVID care that Eugene kind of like mentioned not too long ago. All the IAPT services were able to transition into remote working quite comfortably, and now we are looking at how they will be able to kind of like have that mixed or balanced model of both remote working and face-to-face. IAPT is a very high volume service, so it presents with significant challenge for us to move back into face-to-face almost immediately, and also be able to maintain the COVID kind of like compliance of social distancing and so on and so forth to support people, including infection control. So it has got to be managed, but what we're trying to do is to ensure that we're not creating an inequality at the same time, just because we've moved to remote kind of like treatment delivery. So there's that kind of like balance, and we are monitoring, of course, access for everybody, into services and making sure we are able to address areas where there are going to be kind of like challenges where people cannot get access. And the other thing we're also trying to do, of course, is to support our frontline staff, be it emergency services, be it health and social care clinicians or people from the voluntary sector who are working very, very closely in the front line. So all IAPT services are now fast-tracking key workers so as they're able to get support as early as possible. Next slide, please. I think this will hand over to Sue now.
Thank you, Jane. So in terms of secondary care, what are we doing around our planning and preparation for the wave 2 and moving forward? So as part of our transformation, we are looking at psychological services in our secondary healthcare, so our community mental health teams, about increasing the resources there. We have, similar to everywhere in the country, we have issues around recruitment of psychologists. So we are commencing a training package to help develop associate psychologist roles, so which will be new roles, and we will be providing the training in collaboration with Essex University to create additional roles and capacity in our secondary services. We are looking at developing escalation beds. We are developing a ward. We're in the process of refurbishing a ward in the mid area, which will serve the whole of Essex. Topaz ward, so we expect that to come online mid-January, but with other work that we're doing around inpatient services, we are looking at establishing other escalation beds that, should we experience the surge that we're expecting and demand on inpatient services go up, that we can provide that in Essex rather than looking at out of area placements outside Essex. We're also ensuring that we've got robust gatekeeping for admission avoidance wherever possible to help care for people in their homes. Lizzie talked about the home treatment, and we have home treatment in all of our areas, and we're trying to shore those services up to enable us to avoid admissions. In Mid and South Essex, we have a strategic meeting looking at operational preparedness, which is bringing together all parties, social care, health, non-stat sector commissioners, providers, to look at how we can be responsive to the demands as they materialise. And finally, a focus on throughput, reducing delays of transfer. We've been successful in getting some money for a discharge coordinator, which will join a wider team to help focus on reducing the delays and ensuring that we've got the appropriate throughput into our services. So next slide, please. Shall I do this one, Jane? So this is, if you remember the slide earlier on around demand, that what we know nationally is the indicator of the kind of demand that we're likely to experience by care groups. We've applied this to Mid and South Essex. Now, North East and West are likely to have similar, but it's just to give you a flavour of what kind of demand we're likely to see. And if you look at the people with existing mental health conditions, that the increase in demand can be up to 67%. What we've talked about is that if you then apply it to the local population, you can see the kind of demand that we're going to experience, 8,000 additional cases. Now we're not too sure what time frame that is, and as we go through, it's a constant focus for us to try and establish what time frame these people are likely to present over, whether it's a course of a year. It obviously can't be a month, because when you look at the general population, you know, you're talking about some really big numbers there. What we do anticipate is the vast majority of this are likely to present in primary care, and what we're anticipating that out of these is that we will not all of these will present to services. So I just thought that would be interesting for you to see that, so you can see we were asked to provide some data. You can see this is just Mid and South Essex, so this doesn't include North East and it doesn't include West. Okay, so now I'm going to move on. Next slide, please, and I'm going to hand back to Jane for this one.
Thank you. This is basically our mental health liaison services across the 3 hospitals in Mid and South Essex. That's Basildon, Bromfield, and Southend. And basically what this is showing is that, you know, there's significant activity, you know, across the 3 hospitals of people presenting to A&E, you know, for, you know, probably even for something else, but then they're also supported around their mental health. And I think what is good to note is that when the 247 service became live, that activity kind of like tapered off, because now there was no longer really any reason for people to go to A&E. And then because we also launched the service practically at the same time as we had, you know, we went into the first lockdown, then the activity totally dipped completely. And then, you know, it has kind of like started going back up again as lockdown has kind of like been eased and so on and so forth. But what I just wanted to kind of like highlight with this data is that, you know, even if people are not supported within the community and they end up in ED, all the 3 hospitals have a fully resourced mental health service that operates at Core 24 standard across the 3 hospitals, and they're able to be supported quite effectively to be able to manage their, you know, their conditions and then moved on. And that is where they will either interface then back into their GP services or be supported into kind of like secondary care, you know, support depending on their needs. So that's all I just kind of like wanted to touch on this slide. Unless Sue, you want to add anything else?
No, that's fine. And I think we can pass over now to Lizzie, who I believe is going to do the West information because Peter's had to leave us. Lizzie, over to you.
Coming off my mute and putting my video back on. Hello, everyone again. Yes, sorry, Peter had to leave because he had a commitment this afternoon. So I just want to present kind of the highlights for West Essex on behalf of EPUT and the West CCG. The One Health and Care partnership is the new partnership in West Essex, and we've got something very similar in North East Essex called the Alliance. And in West Essex, it's called One Health and Care Partnership. And that's where all organisations have come together, multi-agencies, the acute trusts, ECC, primary care, the third sector, the mental health trusts, voluntary services, who have come together to help inform and support the delivery of new care models in each area of Essex. And it works really well, and I think it's because we all have different knowledge on local population and the needs, so that knowledge is shared, and there's a lot of experience around the tables as well. So the West Essex All Age Mental Health Partnership Board reports into the One Health and Care Partnership, and that's just been established. I think we've had 2 meetings now, and it's led by Peter Whiteman. The first meeting was held, and we agreed attendees and membership, and partners are engaging with district councils to join as well. So EPUT provide both community health and mental health services in West Essex, and we're able to co-provide and respond to emergent community needs. Work in partnership with the voluntary sector, Mind. We are hopefully setting up a crisis cafe in Harlow with Mind. That's something that's just starting. And we work closely with the Samaritans and the Alzheimer's Society, and they're all embedded within our community model. So there's a refocus now on primary care networks and working very closely with primary care, which is great. I think we've worked in silos for too long, primary care and secondary health care. So we're working very closely with the PCNs, which enables a flexible service. So further opportunities for collaboration going forward with the One Health and Care Partnership and the Mental Health Partnership Board are engagement with housing services, engagement with activity and leisure services, and any other opportunities we're open to, really. Thank you. Next slide. So West Essex Mental Health Services, we were chosen to be one of the first implementer sites, as NHS England are calling us, along with Hertfordshire and Cambridge and Peterborough. And that was due to us being in a good position, because in West Essex, as I've described, we provide community services and mental health services. It was easy for us to start integrating and co-locating, and Hertfordshire were also acknowledged to be in a good place. So the pilots included, and I touched on this when we met in September, the primary care networks in Epping. We've put in some specialist mental health workers into the GP surgeries, mental health coaches, and we also have a specialist mental health pharmacist that's working very closely with the GPs. Part of the community model also includes our new 18 to 25 service, which is psychology led. We also have the FREED, which is the Early Intervention Eating Disorders service, and that's also focused very much on working with people who are 18 to 25. We have the perinatal service, which we touched on earlier. Also, dementia, older people and frailty service is based at St Margaret's, and that's aligned with the actual community service that's based there in St Margaret's. And we also have our first episode psychosis service as part of that new community model. So these elements are all in addition to the generic community teams that you've probably known about for many years. Thank you. So in West Essex, IAPT isn't currently provided by EPUT, but the CCG have put IAPT out to tender for the service, and with, again, very similar to North East, with increased capacity, hopefully starting mid-2021. You can see from the referrals through this year, as reflects very similar to Jane's data, that there's been an increase in referrals and the number of people entering psychological therapies kind of post-lockdown period. Thank you. Next slide. So I talked about the crisis service in the North East. I wanted to focus on our 18 to 25-year-old pilot in West Essex. So as we touched on the mental health investment standard, the new funding stream that's coming down from NHS England, what we did when we did an analysis in West Essex, a lot of the demand was, and this links to Jill's presentation that there was a significant demand for 18 to 25-year-olds for young adults in West Essex. So we decided that we would use some of the money to implement our 18 to 25-year-old pilot pathway. So it's psychology-led, working with young people, and it's about developing strategies to manage their emotional and psychological well-being at an early stage. So it's about that early intervention again. It's intensive support following CAMS. So it might be that some young people have been known to OOMS and are in transition to adult services, which currently are very different. So having this specialist 18 to 25-year-old pathway supports that need and provides a more coherent pathway with CAMS. We engaged with local forums to hear what the young people wanted. A large demand was mostly received, as I've said, via GP clinicians and the crisis service for that age group. Young people are moving to universities outside the area. Advice and support is provided in respect of accessing support to the area that they're going to. First episode psychosis service is linked very closely, and we have a 2-week referral to care plan work with children and young people's mental health services, as referrals are accepted from 14 work in partnership with the IAPT service. So again, that's about working very closely with IAPT. And mental health wellbeing promoted within educational institutions is also happening. So across Essex, we obviously have 2 universities and many sixth form colleges, etc. Thank you. Next slide. So this is just a model that we're using really with all of our service developments in terms of how we've moved from where we were to our new model. So stakeholder engagement has been very important. As I mentioned earlier in the One Partnership, sharing experiences with partners to create awareness of different capabilities across those organisations in terms of how we deliver the service together so that we're not working in silo. Leveraging system-wide capabilities, mapping capabilities across the system so that, thinking about the integration between community services and mental health services and working with people with dementia. At the moment, people might have 2 different nurses going out when actually that one nurse could develop the skill set to deliver the mental health assessment and the physical needs as well. And then as the last thing, it's about delivering services together. So there really is this move across the work I'm doing in North East and West Essex to work much more closely with our primary care colleagues, our physical health colleagues, and the voluntary sector, so that we are kind of having multi-agency care plans is what we're moving towards. Thank you. I think that's complete.
Thank you, Lizzie. I have got 3 hands up: Councillor Wood, then Councillor Harris, and then Councillor Egan. So Councillor Wood first, please.
Thank you, Madam Chairman. Thank you, Sue, and the others for this report. I've got 2 or 3 questions, not very big questions, but there's just a question I want to ask, really. Is the out of area services. Now, in the report, it says that we'll be probably going out of area services. Now, to me, that's probably a no-no, because I've had people go up to Manchester from Essex and the families can't get to them. And if they've got mental health issues, that causes even more mental health issues because they can't see their family, who may well be very supportive of them. So that's one thing I'd like to ask you about, whether we're putting people out. Vice versa, are we taking people in that's taking up Essex beds from other areas as well, which may mean while we're going out? And the other one, Topaz Ward. Now, that's, as far as I can see, that's your overspill ward or something like that, isn't it? Where you might need it. Why? To me, I think if you look at the statistics of mental health in Essex, you've got a big chunk in Harlow where there's a big problem, and you've got a big problem in tendering, and yet we've got a Topaz ward going in the middle of Essex, nowhere near these two areas. And those, to me, are your biggest areas for mental health. I could be wrong, but I think they are too. So I'd like to know why we're putting a ward like this in the middle of Essex, which is nowhere near these two, or not that close to those two wards. And the other question is mental health in doctors, especially in North Essex, that's where I come from. Have we, or are we, because I haven't got one in my, I don't think I've got one in my doctor's surgery. What's happening with the mental health advisory people in doctors? Do we have any in North Essex?
So shall I start by answering the first question, and
Yeah.
then I'll hand over to Lizzie for the second question.
Thank you.
So we.
Oh, very, very faint, Sue.
Oh. It's because I moved my speaker up to my head.
Getting excited.
Hopefully you can hear me now, Chair.
Yeah.
So for the out of area issue is that there's a number of different issues. One is the surge, and two is that we've had to, in some of our areas, we've had to reduce down the capacity of the wards in order to enable social distancing. So for example, on the Basildon site, where we've got dormitories, you would have had 5 beds in a dormitory. Now, we can't maintain the required distance between those beds and keep the 5 in there. So we've had to reduce them all down to 3. Yeah. And we're going through a process of eliminating those dormitories, which, if you remember, I brought a paper to HOSC previously. So we have the demand, and we have also the reduced capacity, and it has meant that until we can open our own internal escalation beds, we've had to use external out of area placements. Now, we've developed a relationship with the Priory in Chelmsford, so we can admit to those in the meantime. But we try and avoid out of area placements at all costs. However, the whole country is using out of area placements at the moment because demand has gone up and people aren't able to manage their beds. And unfortunately, it has meant that sometimes we're placing patients as far afield as Liverpool. And when we do that, what we do is we focus on trying to get them back very quickly. Now, the second point you made there about the Topaz ward and Harlow. In fact, Harlow isn't our highest area. Our highest areas are northeast. We've got an issue across the south at the moment because we've got that reduced capacity in Basildon area. And mid-Essex is our high demands. West Essex tend to consume their own smoke and actually aren't big demands. It's actually in all of the other areas of Essex, they are higher. So using, in terms of why we've chosen Topaz ward, it's because we have the ward available, and secondly, it is actually one of the most central points for all the other areas. I'll pass over to Lizzie now to answer the question about North East.
Thank you, Sue. So yes, just to highlight again, West Essex, I talked about 18 to 25-year-olds. I think demographics across Essex are very different. There are different local population needs, but West Essex, in terms of demand for inpatient beds, it's not high compared to some of the other areas, including North East. North East has always had a high 136 rate, which is where the police detain somebody who on a police detention in the community who somebody who is presenting as with a mental health presentation, and they come to the Trust Health based places of safety on a section 136, and then a Mental Health Act assessment is completed by ECC AMP service and consultant psychiatrists, section 12, doctors who are independent, to make an assessment whether someone's detained or not. And currently all of our out of area patients, and in the North East we have a handful, are detained under the Mental Health Act, so admission was necessary. I think just to reflect, back in 2017 we had a much worse out of area problem in Essex, where we would probably have about 30 people out of area at any one time. So much progress has been made with, as I've talked about, bed management, offloading, our flow and capacity initiatives, and also the development of our crisis and home treatment teams, and you could see how high their activity was. So the home treatment caseload, especially, if it wasn't for that home treatment caseload, people would need to be in hospital beds. But it is now we're moving away from institutions. It's last resort in patient admission, and it's usually under detention and under the Mental Health Act that person needs a mental health bed. So that's how we use our out of area beds at the moment if people need detention under the Mental Health Act. So considering the surge, I think it's a good news story that we actually have a lot less people out of area than we did a couple of years ago, even though we are experiencing a mental health surge with the pandemic. Sorry, was there another question?
Yeah, there was about the PCNs, Lizzie, about presence in primary care.
So the PCNs, we're moving towards the new model in January in Clacton and Colchester. So we're moving away from the psychosis team and the SM8 specialist mental health team back to locality teams. So Clacton will have, it doesn't matter what your presentation is, that team will manage all mental health presentations and work very closely with the PCNs. There's 3 primary care networks in Tendring and 3 in Colchester, which are clusters of GP surgeries. And what we're building around those PCNs is a primary care mental health team that consists of a senior, a band 7 senior nurse or clinician, and we're looking at mental health pharmacist, as we've got in West Essex. The consultant psychiatrists, they're not based in GP surgeries, but they are going to be linked to a PCN. So we've got 3 consultants, for example, that are going to be providing consultant psychiatrist intervention to Clacton, and we've got 3 for Colchester, and they will link and have very good relationships with those GPs as they have previously, rather than focus on a psychosis pathway, for example. Does that help?
Yeah, but can I just come back on 2 things, Madam Chairman? That's all right, please. The first one, Sue, you didn't answer the question about how many beds are being used in our area for people outside our area.
Yeah, no, so apologies for that. None. We do have people from out of our area sometimes will attend A&E, and sometimes they will require admission. What we will try and do is repatriate them to their own area, because we don't have any beds to give away. Sometimes that is a difficult conversation with those areas, because they will ignore us, but if necessary we will place them out of area and allow the other area to pay the bills for that. But we don't as a whole admit, unless it's an extreme patient safety issue, then of course we'll admit on a temporary basis before we can transfer them back to their own areas.
Okay, one more, and it's not probably going to be answered, I don't think. In your paper, and I'm always suggesting this, and I'm going to keep on about this, it talks more about Mid Essex than it does about North Essex in your paper. I'm really concerned, like everything that happens in my area, we get the drips and drabs, we don't get the full services. Everywhere else seems to get it and we don't. And yet I know we've got JWIC, one of the most deprived areas. I've got one of the most deprived children's area in my patch, which is Percy King Estate. And it just worries me. And I say every time, North East Essex, because it's the end of the line, it just stops at Colchester. I'm just really concerned. You're probably going to say it doesn't, but it just comes across to me and my residents. That's what happens. Thank you.
So if I just quickly come in, and then it looks like Eugene's ready to respond. We deliberately did our presentation to divide it into the different areas to ensure that there was a balanced view. And so we apologise, or I apologise if that hasn't come across. I'll hand over to Eugene.
Yeah, just to echo that. Can you hear me, by the way? I've just put my thank you. We are 100% committed to North East Essex, and we are absolutely cognizant of the challenges that some of the most deprived wards in the country throw up. And I know Lizzie and I would be more than happy to take offline any particular concerns to go into more detail and to provide more information about the plans and the conversations that were happening. I think we've probably got something here for future presentations about the consistency of the content. So what I didn't put into the slides, for example, was the work that's happening with primary care networks, with our alliance partners, with VCSE, investment going into crisis cafes in Colchester and tendering, for example. So happy to take offline, Councillor Wood, so to give you that assurance in terms of being absolutely committed from a CCG perspective with EPUT, that North East Essex certainly is no less important than anywhere else in the county. Lizzie.
Yeah, just to add, I think from an EPUT perspective, just to reassure you that there's nothing happening in Mid and South Essex that's not happening in North East. You know, that the model is consistently the same. I think the purpose for today was we just wanted to talk about certain areas due to the time, really, the time frame. But if it would be helpful going forward, we could do a more detailed report rather than a PowerPoint for each area. I think it depends what is requested.
What would be handy if you could is me and the North East Essex guys we've got on this host could have some updates from you. I'll be, if I can, rather than be offline after this, I'll email you my concerns.
Yeah.
We can talk over the emails.
Yeah.
Anything you have happening, could you let Mark Stevenson and the other and Councillor Harris, Dave Harris, know what's going on in our area? Give us an update if you can now and again, please.
Councillor Wood. Before I bring in Councillor Harris, Sue, capacity of Topaz Ward wasn't mentioned.
17 beds, I believe.
Thank you. Councillor Harris.
Thank you, Chairman. Thank you very much for the team and the presentations. My question is a pan-Essex. It's across the whole of Essex, the whole patch, because all areas talk about the surge, is the word you used quite correctly. Now, your cake is this big, and all of a sudden it's becoming much bigger, and that's what you're telling me. So as a scrutiny question, are you able to work smarter? Are you looking to increase your team? Are you looking to match the demand with the service that you've got? Because I'm really worried that what might happen, and this is the scrutiny bit I'm looking forward, we don't end up deferring a lot of the things that may have got looked at in 2019, 18, 17, 16 and backwards that wouldn't get looked at now and get before they get worse. So you see where I'm coming from, this surge and the capacity, please.
Did you want to start, Lizzie?
Yes, so we do have within the trust internal to EPUT, we have a flow and capacity lead who focuses on the whole trust as a pan-Essex as a whole. So we are on top of, you know, the areas where we have a higher demand, and we've touched on some of those. So as a trust at the moment, we do have some pan-Essex services, such as perinatal is a pan-Essex service. So that is about, so more of our specialist services now are pan-Essex, such as perinatal, our substance misuse service, etc. What we now are moving towards going back, and this is about responding to the systems and the ICSs, is that we also have system focused services where we are working much more with primary care, the acute trusts and that local system, rather than working as a mental health trust in silo. So it's kind of the balance depending on what the service is and what the need is to how we're responding, really.
So can I come in also? So in terms of, you know, it's a concern for us, the surge, because we don't have, we can't just throw extra staff in if we wanted to, if we had the money to do it, because, of course, we need a qualified workforce. However, the good news is, and Eugene highlighted it about the mental health investment standard, is that, and Lizzie spoke about it, is that we've seen an unprecedented amount of investment into mental health that's ring-fenced into mental health. Now, we've talked about primary care, we've given you some of the data around what the expected surge is going to be facing all of us across. And of course, we see that change in different areas. We see little spikes, we see some nuances, but generally we're going to see a surge across the whole of the trust, the whole of Essex. And fortuitously, we've also seen an investment into mental health services. So we're beginning to develop primary care networks. We're not taking staff away from our secondary mental health care services in order to develop services going into primary care. So we are seeing an increase in resource going forward. And where we have difficulties in recruiting the right staff, we're trying to create new roles. And I talked about what we refer to as CAP, so clinical associate psychologist, for example, doing some of that psychological training. Now, we're going to get a number of those coming in within the next year. So we are investing and seeing an investment. So I think from a scrutiny point of view, whilst we're concerned because we don't have staff growing on trees, we are making incremental increases in the kind of resource that we're able to offer.
If I could just add to that, Sue, in terms of the development and evolving models for mental health, whilst our specialist mental health services and EPUT are crucial with their expertise and upskilling primary care and raising awareness that mental health is everybody's responsibility, we will now, from the 1st of April next year, be seeing primary care networks using their budgets to pay for mental health workforce. How they work alongside EPUT in developing our community model is going to be essential, and those conversations are well underway. But I'd also wish to draw everyone's attention to the role and the vital role that the VCSE and other partners play in terms of supporting mental health. There's a national direction of travel now, which fits very much with place-based responses and partners working together in alliances, that mental health is supported earlier in a more timely way, and that less individuals require specialist responses. So it's increasingly that how commissioners put funding into VCSE, working alongside and in partnership with organisations like EPUT is a vital step change, which I'm sure you'll be seeing now and further as we move forward.
Thank you, Eugene.
Councillor Egan.
Thank you, Chairman. I think my question is for Jane around the integrated primary care model. I fully support this person-centred approach, and I'm sure, well, from experience I've had in the past, it will become, it's far more effective and efficient and clearly better for the individual. Just recently, I came across somebody where the local authority housing department moved to support the individual's mental health, actually, because they were suffering from issues of, I'm going to call it antisocial behaviour. They moved, they found a GP that agreed to support their medication for their mental health, but not the injections needed for their gender transitioning, which clearly was quite crucial. I'm not sure where that situation has ended. So my question, please, is how long will it take to be fully implemented, the integrated primary care model?
Thank you, Councillor. We have already initiated, and actually we're already resourcing quite a number of the PCNs, and you will forgive me, I will speak about Mid and South Essex in this particular case, and Eugene can cover Northeast and Lizzie can cover West. In Mid and South Essex, as I said, we've got 28 PCNs. In the southeast of the system, we've already started having the clinicians going in each of the PCNs. In Thurrock, we're going to have each of the PCNs also have clinicians really by Q4 also in place. Now, in Basildon, Brentwood, and Mid Essex area, and Castle Point, actually, we already have some clinicians in. We're going to have to start phasing in over the next kind of like year, but definitely by 22-23, all PCNs, all 28 PCNs will be fully staffed with the integrated, teams in place. We will, of course, not have completed everything because we've got to face in. It's a 3 to 4 year project. So, but the crucial thing for us is to get the integrated teams in, so that we have the mental health professionals in terms of nurses, our peer support workers. We ensure that now the psychiatrists actually are able to transition some of the people they hold in caseloads, for example, in outpatients that they're not doing that much with, that these people are now supported with better care packages to release that capacity for the psychiatrists to be able now to come and support GPs in primary care, so that we don't have people actually kind of like moving up and down the system. That there's going to be that seamlessness in supporting people where they need to be supported. So in response to how long it will take, it's going to be phased in. So we are hoping really by 22-23, we should have the whole of Mid Essex covered, Mid and South Essex covered, sorry. Yeah.
Thank you, Jane.
If I could just come in from a Northeast Essex position, the NHS England timescales, as Jane has said, is a 3-year plan from now. Much of that work has already started in terms of effectively within localities having social care, community mental health teams and other physical health teams working much more closely together. For the 10 primary care networks in Northeast Essex, we've recruited 7 nurses for 7 of the primary care networks. The conversations are happening with the PCNs at the moment about do they wish to recruit directly, or do ePut provide on their behalf, for example, in terms of the different models that can work. We've also committed to working with the PCNs to hear what their local issues are. So that whole place-based approach about what the need might be in one PCN compared to a different locality is part of the conversation. So I would imagine and hope that in the next 2 to 3 years there's a marked difference and noticeable in terms of within localities about how mental health is working. And I think the key thing is it's that relationship between specialist mental health and support in the primary care in the community, and that interaction should be much more seamless in terms of how patients access that support in a timely manner and don't require formal referrals in and out of a specialist mental health provider. That's one of the key measurements that we'll be looking for.
And I do have to say that place-based with person-centred just adds to the whole scenario. So it sounds very encouraging.
Right, thank you for that. And a final councillor that is going to be asking questions on this item is Councillor Edwards.
Yeah. Sorry, I'm just trying to unmute myself. Unmute.
You're still muted, Tony.
Apologies.
You've now turned your video off.
Can you hear me now? No.
Yes.
My video.
Do you want your video on? Still can't hear you. You're muted.
Unmute me, Richard.
Yes.
Can
No. Okay.
You hear me now? No.
Yep.
You can.
No. You're muted now. Can you unmute yourself? Fine.
Yeah,
Don't
done.
touch anything. Stay as you are.
Richard.
Right. Talk away. Fine.
Can you hear me now?
Yes.
Yeah. Oh, brilliant. Thank you. Sorry about that.
Keep your hands to yourself.
I don't know what's going on. I've got 2 questions. One, in terms of the numbers of people that are out of county, you spoke about it being lower than it was in 2017, but I still haven't got a feeling for exactly how many people are placed out of county at the moment. And neither have I got a feeling for how, and you also spoke about trying to get them back quickly, but I've got no feeling for how long they're out of county for, you know, how far and how long for.
Do you want
The
to
other
respond,
thing,
Lizzie?
yeah, sorry, and just on, and the other thing is, and I might be asking the wrong group here, and if I am, I apologise. Do we know the numbers of adults with mental health, with learning disabilities who are currently detained out of county? And if so, how long for? That was on that. And the other point I just want to make was in terms of the report, I didn't get a feeling of the user voice within this. So could you tell me what mechanisms you've got in place for assessing what both the users and carers of, you know, service, both service users and their carers, what their views are in terms of the service, how you obtain their views in terms of the services that are currently being provided?
Okay, so I'll start with the out of area figures. So from memory, back in 2017, the trust across Essex had up to 45 people out of area, which is 2 wards really. The majority of those were from North, East Essex, Mid Essex and West Essex. And that was because South Essex didn't really have an out of area problem. However, at the moment, when I looked earlier in the week, we have 21 people out of area. And that's due to, as Sue said, we've had to reduce our bed occupancy to 85% to manage COVID infection control. There's also the issues with the dormitory changes at Basildon. Once Topaz opens in January, that will, as Sue's described, give us another 17, 18 beds. So that should then actually take the majority of out of areas that we currently have. But what's happened during this lockdown, we did have a surge where we hit OPEL 4, which is the escalation level that the NHSE and everyone recognises in the acute trusts, where actually our demand in Essex was high, and we hit OPEL 4 once, and I think we had a near miss over the lockdown period in November. So I think that really impacted on how people were feeling and coping. So that's kind of the overview of where we are this week and where we were in 2017. So we're in a much better place, obviously, with the than we were, and we have the surge to manage, and that's due to our transformed community crisis services that we've talked about. So in relation, sorry, remind me of your second and third question.
The second bit was about adults with learning disabilities.
Yes, so we do have people who have we have in our inpatient services, we do have people with mild to moderate learning disabilities that can be many things, Asperger's, autism, for example, and those people are managed the same as anyone else. I don't know if anyone is out of area with autism, for example, but the Learning Disability Trust manages the moderate to severe learning disability, so I can't comment on that, I'm afraid. I don't have those figures.
My other question was about the service user voice and the carer's voice in terms of how do you how do you
yes, and I think going forward, that's something we should definitely ensure is in the report or the PowerPoint. What we do is in Essex, in ePut, we have a service user forum group that happens monthly, where they are involved in all of our transformations and service plans. Their views are incorporated into that. We also take feedback from compliments and complaints and analyse people's experiences in terms of that, helping inform our future developments. And then in each system, we also have service user involvement in different projects. So yes, there is service user involvement in all of our service developments.
So if I could just Sorry,
quickly add from an EPUT perspective, all our transformation plans have service user and carer engagement in them, in designing and developing and taking forward.
If I could just underline the commitment to co-production and how there's been a cultural shift, particularly how the NHS works in the last couple of years. No, sir, as far as our governance is concerned, one of our markers in terms of pursuing any service transformation or any investment asks that question and challenges us now, quite rightly, in terms of how co-production has worked. So not moving away from the traditional lip service of sharing an output and then getting a rubber stamp. Our expectation of co-production now is that our users are involved from the start in the inception and the development and then the final product. So that is a commitment that not only do we hold ourselves to account to, but also how NHS England holds us to account. So any submissions that we've recently made a submission for funding for community transformation, one of the key assurances they're seeking is, well, how can you demonstrate what that co-production tangibly looks like?
Thank you very much.
Members, I'm being pressed to push this on. I would like to thank you all very, very much indeed. I do apologise for the wait earlier on, but I think this is one of those situations where, you know, you have a big presentation to make, as did Jill, and, you know, we have some quite searching questions. And that all takes time. But can I thank you very much indeed? I think at some stage in the future, we would like an update, obviously bearing in mind the COVID situation. So can I thank you all for your time? And, you know, apologies once again. We're going to move, we're just going to jump an agenda item because our presenters for item number 6, interpreting services, have until 1:30. So I'm going to take item 6 first and then go back to 5 and then go on to 7. So please, item number 6, Fiona Thiedham and Simon Morgan. Thank you very much.
Thank you, Chair. Thank you.
Hello. Sorry, can you see me?
Fiona.
Yeah, sorry, I'm not used to Zoom. Apologies.
Fiona.
Thank you very much, Chair. If I can introduce it very briefly, and then I'll hand over to my colleague Jessamy Kinghorn to talk about the engagement process. Very quick background. We've got multiple arrangements in place for interpreting services across the region. And what we're really trying to achieve with our plans is to ensure that we have a consistent and equitable approach across the region, which also addresses health inequalities for non-English speakers and the non-spoken community in how they access primary care services. At the moment, services are primarily available for patients accessing GPs and dentists. And what we plan to do is open it up to all 4 primary care services. So that's GPs, dentists, pharmacies and dentists. We're very keen to receive feedback from our engagement. And obviously this is part and parcel of why we're here today. Because it will be important to inform what the service model looks like. I mean, essentially, we're commissioning telephone services, face-to-face services, and also looking at the development of virtual online services, which obviously will meet the changing face of how primary care is currently being, how primary care delivery is changing. But I think it's really important to note that patient choice is still important from our perspective. We wanted our engagement process to be robust, although proportionate, and have the time and opportunity to listen to patients and key stakeholders. And this is one of the reasons why we've asked to extend existing arrangements to 2021, which is not necessarily ideal, but we feel it's far more important to have that time to listen. We also recognise that we really need to engage with our practices and primary care services and patients throughout 2021, and really to raise awareness about the availability of these services. I think that's one of the key themes in terms of the feedback that we've been receiving from engagement. I will now transfer over to Jessamy, who can update you on that process.
Thank you, Fiona. Thank you, Chair and Councillors, for having us here. My name's Jessamy Kinghorn, and my role in NHS England is Head of Partnerships and Engagement, and that includes making sure that we hear the voices of patients and stakeholders and staff and public and so on in the services that we commission. For this particular piece of engagement, as Fiona said, it was really important to us that we heard from people who use the services so that we commission the right services rather than simply going through a contractual process. And it's been a real challenge. I think this year in particular with COVID, we have had huge challenges in contacting groups and finding people to participate. We found that a lot of voluntary and charity organisations aren't working in the same way, so there is a more limited pool of people. We've had challenges trying to go directly to patients to ask for their participation. We have an organisation that is leading this work for us so that they can put all of their energies into it. And at the moment, they've contacted 243 organisations across the 5 STP areas, so that includes the Essex area. And they have carried out 64 interviews to date with patients who've accessed translation services at some point. So that's been an in-depth interview with an interpreter. And that's on the interpreting side, and I'll come back onto the other side shortly. So in Essex, the interviews have taken place in Polish, Portuguese, Kurdish, Sorani, Cantonese, Bengali and Urdu. We are still having difficulty in finding people to tell us about their experiences of accessing interpreting services in primary care from the Lithuanian, Romanian, Russian, Arabic, Bulgarian and Hungarian communities, which we'd set out to engage with based on the languages that are most commonly requested or people most likely to declare they're from across Essex and the wider region. So some of those languages, like Russian and Eastern European languages in particular, are universally difficult across the whole of the region. As Fiona said, some key issues though from the interviews that we've been doing have been arising, and those include some communities that find that there's a lack of support for accessing primary care, that we found that GP practices need further training, and some other issues around medical letters. So it's not just about accessing the appointment, it's about the ongoing communication with practices. We've used 2011 census data, which is somewhat out of date now, but is the latest census data available to us. And we've used the interpreting requests that have come through for primary care, and we've checked in with the acute trusts about their interpreting requests as well, to try and gauge what languages we think are most required across Essex, to make sure that we are engaging with those individuals. I think in Essex, according to the census, about just short of 6,000 people don't speak English well or at all, which is just under 0.5% of the population. I think we've seen that there are issues for people that don't speak English. But we've also doing a piece of work for those with sensory impairments, particularly hearing impairments. And we've heard some powerful stories from people who have difficulty accessing health services because of their hearing loss. And also we've got figures and estimates on what percentage of the Essex population that applies to. So across the region, the engagement has been really useful, and we're carrying on. So we've still got plans to address some of the gaps over the next few weeks. The engagement is designed to really, as Fiona said, inform what interpreting services required. But it's fair to say that as we've gone through it, there are some other things coming out of it, and there's potentially some wider work that we need to look at doing in the future around wider issues about access for people who are either perhaps not speaking English, are sensory impaired, or are vulnerable in other ways. And one piece of work that we're also doing at the moment, we're just about to start, is a digital exclusion project, which is really looking at the impact of this rapid move to remote care that we've seen because of COVID, and how that's affected people, and where inequalities might have crept in. We recognise that actually it's an opportunity to reduce inequalities as well. So there's a lot of work going in. So, I mean, the reason for coming here was to talk about the interpreting services procurement and the feedback that we are getting. We're trying to speak very much to those communities and those individuals who require interpreting services to make sure we meet their needs and we don't assume or do a kind of more general piece of engagement and make assumptions, which I think is what's happened previously. And then out of that, I think, is coming some thoughts about what more we might need to do in the future, sort of beyond this particular procurement. So I think that's all I thought I would say, but I'm sure Fiona and I are happy to answer questions, and I think Simon should be here as well from the CCG, who's been very supportive in the work that we're doing.
Thank you very much, Jessamy. Councillor Rees, is it okay just to add a few comments to that,
Yes,
please?
of course. Carry on.
Thank you very much indeed, and good afternoon, everybody. Just wanted to highlight some of the work that we're doing in terms of engaging with our communities. We do have a number of support groups and networks that we have access to, and we'll be working with Jessamy and Fiona to ensure that we do tap into those, effectively. And in the past, we've had some very good support from members of this group to get messages out to our communities, and we very much like to ask for your support again as we progress and support this work with NHS England. We have been doing quite a bit of work also with our colleagues at various support groups, as I mentioned, in particular Community 360, Community Voluntary Services and Tendring, and also over in the border with the Ipswich and Suffolk Racial Equality Council to target our BAME communities. And we have started, and we have been doing for some time now, been translating video messages fronted by our local community champions to ensure that communities do understand messages that are coming out from local authorities and other partners. So we'll be looking to do that again. So that's what I wanted to say, and happy to take any questions. Thank you.
Thank you, Simon. I've got one. Has there been, sorry, I've got a frog in my throat. Since COVID, has there been a specific rise in the take-up of this service since the COVID kicked off in interpreting, using of the interpreting services? I don't mind who answers.
Yes, shall I answer that?
Yeah.
I think actually our big concern is actually we saw a drop-off in use of interpreting services over the past sort of six to 9 months, which is actually a real concern and something that we are picking up and addressing. I would say that we have seen an increase in activity since September, August, September, when GP practices really started to restore their services. But what we don't know is whether it's because patients were concerned about going into their practices or talking to their practices, or what other reasons there might be behind it. But as long as we continue to see a take-up increasing, that will provide some assurance. But yes, it was some concern to us.
And a surprising one as well. My other question is, it was 5.8, and you say patients have been given up to 6 weeks to respond. What is the cut-off date on this?
So we originally said 6 weeks because we felt that would be a reasonable time. But what we've actually done is to extend that to the end of December. So it'll be around about, yes, probably double the 6 week period now.
Right. So,
and obviously we are very happy to take feedback, even after that. You know, this is an ongoing process. This is not a stop-start process. It's important that we get that feedback.
right, thank you very much indeed. Councillor Harris, you had your hand up earlier. Did you want to say something? Because your hand's gone down again.
No, my question was answered. I thought of a question, but that was answered in this text. I quickly took it down again when it was answered. Thank you.
Right. Now, I don't appear to have any hands up. Does anybody have any questions that they would like to ask? Or does that mean you're all very supportive of this agenda item? And we can give Fiona full support? Yes? Got a thumbs up sign. And you say in 6.3 a further update will be available. Yes, at some point when you think that this is the right time for you, then please do come back and we'll hear from you how everything has gone. Happy with that?
Chair, thank you very much, and we'll be very happy to come back. I would imagine that we would have a reasonable update in the spring, and I'll be in touch with Richard and about that.
Lovely. And we've got you through in by 12 past 1.
Thank you very much.
No problem at all. Thank you very much indeed. Members, can we just have a 5-minute break and then we'll come back to item 5. And then Mike McHugh, who's been sitting there incredibly patiently, can have the floor. Okay? So if we can all be back here, say it's just coming up to 20 past, please. So if you want to take your...
We can go whenever you're ready.
We'll just wait for a few more people making for...
My bits and pieces up.
Right, well, I think it's now 1:20. We'll kick off. Right, members, thank you very much indeed for that. We'll move on to agenda item 5. I have asked Councillor Andy Wood if he would like to lead on this, which he has accepted. So, Andy, do you want to say anything to start with, and then we can pass over to Mike McHugh?
Yes, please, Madam Chairman. This item is very important item at the moment. One is I actually had a conference at Manchester a couple of years ago, 2017-18, where we were looking for a zero tolerance on suicides. So with that in mind and what's happening with pro-COVID and also I have learned in the past few months. I'd like, I want this to come through, so I'm really pleased. And I think if I could then lead it now to Mike to tell us more about it, please.
Thank you very much, Councillor Wood and Madam Chair. So yeah, Mike McHugh is my name. I'm a public health consultant, and I've been working with Essex County Council for a couple of months. I'm here on an interim basis. So the paper I hope you will have had a chance to read. It basically captures the latest data around suicide. What are we doing about it, and also what perhaps we need to do about suicide in Essex. And the first thing I'd say is that the suicide data that we have is the latest data we have is for 2019. That was recently published by the ONS, and it covers up until the end of 2019. We don't actually have any definitive information on suicides since the onset of COVID, but I will come back to that later on. So the very latest data from last year shows several striking things, I guess. One is that Essex does have a higher suicide rate than national average, and has done actually for about the last 5 years. Currently, we see about 150, somewhere between 150 and 165 suicides every year. And as I say, that's higher than national averages. And that rate has been going up. And again, that's slightly out of kilter with the national averages, which were starting to go down, although there has been a recent upsurge, again, nationally. And within Essex, there are also some kind of stark statistics around some of our districts, so that we know, for example, that Harlow, Tendring and Colchester have suicide rates that are, well above the national average. And in fact, if you looked at all of the districts in the country, Harlow, Colchester and Tendring would be in the highest 10 out of over 200, 270, I think, districts. So we have certainly got high rates. When you look at the information from the ONS is quite high level, the most we can say is the sort of age groups, sex, etc. And what we know locally is that our suicides tend to follow national patterns. In other words, much more common in men, 3 times more common in men than in women. Commonest in middle-aged men is the commonest group that you'll see suicides. Interestingly, I know we've had a lot of talk earlier about mental health services and so on. Only a quarter of suicides have been under the care of mental health services, although a lot of the people who take their lives have seen their GP in the previous 12 months for different reasons, not always related to mental health problems. It is estimated that about 90% of people who take their lives do have underlying mental health problems. So coming back to COVID, and we heard earlier on today that there has been a significant increase in mental distress and mental illness identified on the back of COVID, or since COVID has started. And this is confirmed in national surveys, etc. as well. As I said, we don't have ONS data confirming suicides since COVID has started anywhere really in the country. But about 1/6 of the country is covered by real-time surveillance. Essentially, this is where the police, who attend pretty much most of the suicides in the community, visit the scene and fill in a sudden death form and record quite a lot of information about that suicide. And that's then fed into the local public health team. This is called real-time surveillance. And essentially it provides a very timely and very granular information about suicides. About 1/6 of the country currently has real-time surveillance. And Manchester University has recently published an analysis of real-time surveillance in those areas since COVID started. And there hasn't been an obvious increase, and it's something of a surprise, but that seems to be where we are in terms of suicide. Anecdotally, talking to our local coroner's office, they do not feel that there has been an increase locally either. So I think that's probably slightly surprising to people, but of course we are concerned that there are caveats around the data, and of course COVID stress continues. We've got economic impacts ahead, etc., etc. So there certainly is no need for complacency around suicide on the back of COVID, I would say. As I think Jill mentioned earlier, suicide in children is often, the culmination of complex history, and I would say that probably stands for adults largely as well. So in terms of trying to reduce suicides, we have to address that kind of multiplicity of risk factors that we see, in people who take their lives. Public health and local authorities are now leading and coordinating the collective efforts to address suicide. And there is a Southend, Essex and Thurrock suicide prevention group, which was meeting every 6 months and hasn't actually met since the onset of COVID. But there is a suicide action plan and strategy that sits underneath that group. And there are many actions, and you'll see those in the paper as well. The other thing that I'd say is important to make people aware of is that the NHS England has released funding down into the ICSs to support suicide prevention work over the last 3 or 4 years, and currently most of Essex is now covered by that funding. The last remaining bit, which is West Essex, the ICS is going to receive its funding in April of next year. And that funding tends to be spread out across different programs of work, including training and awareness raising, support for communities, those high-risk communities, community grants and so on, work on self-harm and so on. So I've highlighted in the report I think the areas where we probably need to be doing more to get a better grip on this issue. I think it's important to strengthen the governance around suicide prevention. As I said, the main group hasn't actually met since the onset of COVID. So I think that needs to be re-established and re-energized as soon as possible. And we will be looking at refreshing the strategy. I'm particularly concerned about the districts where we have exceptionally high rates. And I propose that we will establish task and finish groups. One looking at Harlow and probably a combined one looking at Tendring and Colchester. I think it's pretty important, and COVID has brought this to light, that we really need to get real-time surveillance established in Essex, because that is really the only way we can get a very timely and detailed understanding of what the risk factors are and what sort of things we can do. There is a gap as well in Essex around support, bereavement support for those who've been bereaved by suicide. We know that suicide has a massively devastating impact on families and friends and so on. And we also know that relatives and carers of victims of suicide themselves then are at risk of suicide. So there's a gap, and there's work going on to try and establish specific suicide bereavement support services in Essex. Other work that we're hoping to progress is supporting primary care around suicide prevention as part of the WAVE funding and so on. And just generally trying to raise the profile of suicide prevention across Essex. I'm hoping to establish a sort of a bespoke website just where we can collate and all the resources that are available for the communities and also for professionals as well. There isn't a lot in the paper about children and young people, and I know it was covered earlier. But what I would say is actually that what we would expect, I mean, obviously, as Jill said, suicides in children and young people are incredibly tragic. We probably expect to see about 1 or 2 a year on average. And that, of course, because they're small numbers, means that you can go a year or two and not have any, and then maybe have 4 or 5. Back in 2017, there were about 8, I think, in a short period of time. And a very systematic thematic review took place, and there was a learning event and a conference on the back of that, and a load of recommendations came out as a result. I'm aware that there's been probably something in the region of about 10 suicides in the past 3 years in children and young people, and of course not all of them are under the mental health services. And I think the one thing I would say about children and young people suicide, they tend to be examined forensically through the child death overview panel processes to try and learn lessons and to get people to collectively come together to kind of put in place mitigations around children's suicides. So, in summary, I would say that we're certainly seeing more suicides than we might otherwise expect, perhaps in Essex and in some of our districts. And there's a lot of good work, I think, already underway, and we need to strengthen and build upon that work. And some of the recommendations within the paper are highlighting the areas that we particularly need to focus on. So I'm happy, obviously, to take questions.
Thank you, Mike. Right, it's open. Whoever wants to answer a question?
I'm just going to jump in there. Was that right? You said, Mike, that only a quarter of suicides have been under mental health services.
Yeah, that is a sort of a national figure. We don't have that for our recent suicides, but that is a nationally accepted figure. So many of these people who take their lives of either don't, well, not many, but some don't actually seek any help at all. Some are under the care, for example, of the GP with common mental health problems and so on. But yeah, not as many as perhaps you might expect are already under acute mental health services.
And my other question is, and it seems awful to ask this, but are there many experiences where there are joint suicides, where there is a pact?
As I say, from at a local level, I'm not aware of any recently, and I think it is extremely rare. I think it is very, very rare.
Right. Okay. Hands up. I don't know who was first, so let's go alphabetically. John Baker, then followed by Mark Stevenson. Thank you. John, you're muted.
Thank you. Sorry. That was really very interesting briefing. Thank you very much, Chairman, for allowing me to ask a question. Could you just clarify a little bit more about youth suicides? Because the response I got earlier in the meeting was concerning a 14-year-old in my division way back in July, and I have raised it on a number of occasions, but this is the first time I've been made aware that different parts of the health service are overseeing suicide in different ways. And the suicides mentioned earlier, tragic as they are, were all linked with 3 children, young people, I don't know where they're from or their ages, from hanging, but the one that I'm aware of was on the mainline railway. And I won't name the person, obviously, for the family, because I worked with them quite closely at one time. Could you just explain how, you mentioned real-time analysis, because to only have data up to 2019, we're now December 20, that sounds to me very out of date. I mean, so sorry, I'm sort of meandering a bit, but could you just clarify as concerning young people? I'm assuming that's up to age 18, and the publishing of data or the awareness of the data. Thank you.
So I think there are distinctions in terms of, if you like, scrutiny of adults and children's suicides. As I said, in adults, it's a very laborious process to be identified as a suicide. It has to go through the coroner's system, and there's at least a 6 months lag between an event happening and that, the inquest and so on. And that's the information that gets collated at ONS level. And currently that's what we've got access to in Essex. Places which have real-time surveillance, for adults, the police, as I said, collect that information and they say query suicide, essentially, and they feed that information through to the public health team, usually, to collate that and coordinate it. And whereas it hasn't been confirmed through the coronial process, the information is really valuable in terms of looking at patterns and trends and so on. And I think that's where we need to be going. We all need real-time surveillance in this country, and I think probably in 5 years' time, every place will have it. We've had discussions with the local police in Essex, and hopefully we're progressing that, and hopefully that will be rolled out soon. With children and young people, they will also go through that same process, but as well as that, any child who dies in Essex will immediately be come under the Child Death Overview Panel process, which is a multidisciplinary panel which looks at all deaths of children to see are there any identified risk factors or preventative actions that can be put in place. And not all of those children will be under the mental health services, but if they are, then the mental health services themselves also do generally a serious review. So there's a lot of very quick scrutiny of those cases. I suspect the one you're mentioning, although I can't be sure, may not have been under the mental health services. But I would say if there is any reassurance about children's suicides, is that they are generally investigated quite quickly and in great detail.
Okay, that's very helpful. Thank you very much for that clarification.
Mike Stevenson, please.
Yeah, I'm Mike today, am I?
Mark, I'm sorry. I'm sorry.
It's all right, no problems.
Senior moment.
Mike, thanks for your presentation. It's very interesting. Couple of things that just sprang out. So the ONS data, it's interesting how it actually does quantify children's suicides and the way it goes about that. There's certain ages where it doesn't qualify as a suicide, it qualifies as something else. And so there may be more than we think there is. I'm hoping that's not the case, but that was the first point, and I think we needed to recognise that. You talked about setting up working parties, and you discussed one for Harlow, and then you combined Colchester and Tendring. And I was wondering why we wouldn't have separate ones for those rather than combining them, because there might be different underlying issues, and I wouldn't want to see the work of the working party being muddied with a different point of view. So you can come back on them, please.
Thank you, Councillor. Yeah, I think the numbers of children's deaths, suicides that don't get recorded on us is, I would say, extremely small, very rare. I mean, I think there is some underestimation of suicides, probably more generally, because according to the ONS figures, because you have to get a definitive conclusion through the coroner's system. But actually the coroner's threshold for judging a suicide has been lowered to kind of on the balance of probabilities. It used to be beyond sort of reasonable doubt. And I think we are going to pick up more that perhaps didn't get necessarily recorded previously. In terms of this task and finish groups, I did think about having 3 separate groups, but part of the reason for, and it hasn't been definitively decided, but part of the reason for combining Colchester and Tendring was to do with the, if you like, the NHS footprint, which is the North East Mental Health Alliance, because we're going to be bringing in colleagues from, mental health services, from primary care and so on. And it's just trying to be pragmatic in terms of meetings and so on. I mean, I haven't completely ruled it out having 2 separate ones for Colchester and Tendring, but I suspect, it's yeah.
Go on. Can I suggest that you do have 2 separate ones, because we do have, as Councillor Wood posted, an end-of-line mentality down in Tendring. And what I'll give you a classic example. The Alliance has just set up some sort of a group. I can't remember what it's called at the moment. We had a briefing on it a couple of days ago. And they sat there saying that it was there to help the deprivation and everything else that was going on, and it was going to do all this work around inequalities and everything else. And the very first group they set up was in Colchester. And the most deprived area was in Tendring. And I questioned, when are they going to set up the Tendring one? And they said, it's second on a list. And I said, when? And they couldn't give me an answer. And they gave me some sort of reason for why they did it in Colchester. But that's kind of illustrating my point, is we kind of get passed over, even though the motherhood and apple pie of deprivation and inequalities is sprouted, the reality on the ground is very different. And I think if you sat there and did one working party for one area and one working party, you might actually pick that up. So that's just my thoughts. Thank you, Chair.
Next I have on the list is Councillor Harris. I don't know, he's disappeared.
Thank you, Chair. Playing devil's advocate for me, I mean, I thought there'd be a lot of duplication having 2, but whatever, it's whatever you decide. For me, the task and finish groups that you were talking about, Mike, could I ask and tease out of you, please, in your professional opinion, because I'm just a lay person, what the task and finish groups would actually look at and what they could do to make things better? I mean, the doing things. I want to know what the doing things that would happen. You can do analysis, but what were the positives that would be coming out from the task and finish group that would make recommendations that would make things better?
Yeah, thank you. That's a good question. So I think I alluded to how complicated and complex suicides are earlier. Basically, we're looking at a combination of risk factors. Sometimes it's to do with wider determinants of health, deprivation, employment, and so on and so forth. Sometimes it's to do with, there can be an element that services may be a factor. And I think people who are local to that particular area have a really, a kind of good understanding of where there might be gaps around. For example, as we're coming into COVID and post-COVID, what sort of support have we got in place for those kind of individuals who potentially are going to be made unemployed or are going to get into debt and so on? What do we know about support services more generally, either through the voluntary sector or through statutory services? And it's about working on all of those kind of elements, working on awareness raising, making people aware that they can access support if they're starting to get into crisis. And sometimes there are local nuances around that are hard to kind of get into at a county-wide level. And I think, for example, I think the VCS will have a big role to play in this in terms of helping us to understand and to put in place interventions. Using some of the NHS funding I mentioned earlier, there is a certain amount of that funding is being allocated to community activities. And we know clearly that middle-aged men are a big target group in terms of suicides. So there are different initiatives that we might consider putting in place for particular subsets of those people at risk, for example. And I think local intelligence can help you to direct and to focus that work.
But Mike, I mean, what would the task and finish do? Who would be consist of? Some of us, would it? Some other people, I'm guessing.
Yeah, so it's people. It would obviously be the district councillors, people from the district council, from the local health services, including primary care and secondary care, VCS, and the police. Just to name a few of the core people, and Samaritans actually.
There would be outputs, Mike. Would there actually outputs that would actually be doing things?
Yes, I would expect that actions would be taken back into those different partner groups to if we identify issues and if we set potentially if we need some more funding and resources, actions will come out of that. Where do we get those resources? How do we deploy those resources? How best to get the maximum out of them?
Okay, right, Councillor Wood, then Councillor Edwards.
Sorry, Chairman, I was reading up my board. Thank you, Mike, for that thing. And also, thank you for the letters or the emails you sent me over the past week or couple of months, giving me details of what's happening. I'm really, really pleased that at last someone at Essex is actually taking this on, because for 2 years I've been saying that Essex is one of the highest in the country and no one's taken any notice of what I've said. So I'm really pleased that you're there to challenge this for me. Now, there's two things I want to ask, but the first thing I want to ask you is, you sent me an email on the 15th of the 10th, and it's just coming on what Councillor Stevenson said, where you've mentioned that you've got a strategy, I can't pick it up, as part of Southend, Essex, and Thurrock, but it's down south again. So I'm challenging now: are we, as tendering, going to be supported more? Because it always seems to be the first things that happen is always in the south or mid of Essex, and then when they've decided or when they feel they want to do it, they then come to tendering, which is too late, because tendering is one of the most deprived areas, and in your report it will state that it's more common to have suicides in poverty, in places of poverty, and that. So that's one. The other thing I would like to ask you is COVID-19. Now, hopefully, we've now got a vaccine, so hopefully we've got over the biggest part of COVID. But as we had, and you mentioned this in one of your letters to me, in the 1930 depressions, we had masses of suicide. It was up by 3 times more than it is now. Coming out of COVID, now we're still going to have a lot of people have lost their jobs. So I'm concerned that if you look back at history, we could be seeing a lot more problems in Essex, and in fact tendering in Essex with this once it kicks in, because obviously you're telling me that you're probably 6 to 9 months behind your figures, which is quite worrying, really. And also, the other question I want to ask is, why does it take so long for the coroner to give us a verdict? Because 6 to 9 months is a long time, and a lot of things can happen in that time. And if we don't get data until those 9 months later, we don't really know what is going on in real time. So those are the questions, I think. Oh yeah, the other thing is, sorry, Mike. The other thing is, I was under the impression after listening on the Health and Wellbeing Board the other week that the chief executive of tendering was going to take on the task and finish group for tendering. I don't know if I think you was there at the time, wasn't you? So I was under the impression that he was going to take that on for tendering. And be quite honest with you, as Mr. Stevens said, we do need one separate from anyone else in tendering. Thank you.
Thank you, Councillor Wood. So I'll try and take those questions in reverse order if I can. Yep. I think it's coming across clear that we probably do need separate groups for tendering and Colchester. So I'll take that away. As to why the coroner's processes are so long, it is the way it is. I'm afraid it's been that way for years and years. It's a legal process, a lot of legal ramifications, and so that you have to go through due process in relation to that. And this is why real-time surveillance is now being kind of used and is hopefully going to replace our dependency, if you like, on the coroner's systems, because for our purposes in public health, we need that information straight away, and we need it in much more detail than we can currently get. And that is the way the world is headed. I think we will have that in Essex, hopefully over the next number of months. The question about the wider suicide prevention group, there is an expectation, nationally, that there is an overarching suicide prevention group covering all county council level geographical footprints. They tend to actually work best when they cover the footprint of the police, actually, and as the police the Essex Police cover Southend and Thurrock, that has been the way the group has been set up. But this is one of the reasons why I think we do need those sort of subgroups. I mean, the wider group is a strategic group. I think the sort of subgroups are the groups which will really get into the detail and do some of the work, and that's why we are looking at establishing one for tendering. And I'm not sure if I answered all of your questions. So you're on mute. I think you're on mute. Yep.
It was to do with the loss of jobs due to the COVID-19.
Oh, of course. Yes, yes. What we know historically is that recessions do tend to lead to an increase in suicides. And although there is, the expression I've heard recently, recessions can damage your health, but austerity kills. So it's how we respond to the recession that is coming. Undoubtedly, the risk factors for suicide include poverty, unemployment, debt, and so on. And if those things are increasing, then we need to do everything we can at a local and indeed a national level to mitigate the impact of that.
I just come back on something, please, Joe, if you don't mind. I know it's late, but it's really important to me that I get these answers. The other question is, you were talking about the police involvement and Southend and Falk and everything.
Yeah.
I understand that, but statistically, if you look at the figures, of Essex, North Essex is higher than the South, and yet, as I said, we need to be a bit more parochial. We need to come out of the box a bit and do things slightly different, because while we look at an area which has got less suicides than an area that has, we're not solving any problems. We've got to solve this problem. The only way I think we can solve it is coming out of this box and doing everything as, mechanically, and just come at the bottom and look at it properly in that respect. So I'm really pleased now, after 2.5 years of me banging on about this, that you, Mike, has actually sent me these emails, and it is quite positive, and I'm really happy. What I don't want it to do is, I don't want this to be just in the frying pan for 10 or 12 weeks, and then all of a sudden we forget suicides and we go off on other things. This is very important. We must get this right for the people of Essex. Thank you.
Councillor Edwards, and then Councillor Mark Stevenson.
Hi, Mike. I'm from Harlow, as it happens, and which is one of the areas that's specified here. I've got a couple of questions, really. One relates to the use of statistics and where we are in terms of the statistics. In terms of the report, I think on para 3.1, you say, where are we? I've lost it now. It's about saying at the moment sorry, take myself back. First of all, in terms of the paragraph, you said we don't quite understand why at the moment why the rates are higher in Harlow, etc., or tendering or whatever, particularly as they appear to be in terms of the Harlow ones. They're higher than expected for the socio-economic rankings. There was a study done way back in the 80s. I used to work in psychiatry in Harlow. There were studies done in the 80s and the early 90s, and at that time, depression, Harlow was recognised as having a greater proportion of people, young people in particular, who were depressed, etc. And there were a whole lot of issues around suicide amongst young people that were being addressed, and say depression amongst young people that was being addressed at that time. So in essence, it's not a new problem. So coming back to my question, in terms of are you collecting data in terms of breakdown, in terms of those who are that committed suicide by their inpatients, those who are outpatients, those who are not connected with the services, and are you currently collecting also data around the sort of around their socioeconomic the socioeconomic standing? And is any work being done either with the universities or whatever to actually sort of look upon it as an academic piece of work that possibly needs to be addressed? That's my first question. Sorry.
Okay. Thank you. So what I would say is, in terms of gathering the information, currently we do have some limited access to the coroner's data, where we can go in and interrogate some of the data. And in fact, we do an audit, and one or two of my colleagues have been in the last couple of weeks. It hasn't been done for a couple of years, to dig out some of the cases, to identify a whole range of life cycles. But as things stand and the way the service is set up, it's really difficult. It's really challenging to do that. To 160 cases a year and so on. And this is why I keep coming back to real-time surveillance, and I'm pushing very hard for this, because that's actually what real-time surveillance does. It tells you, the form you fill in at the site gives you all of that information, the demographic profile, recent history, the family will tell you what's been going on in that person's life, any history of alcohol abuse, and so on and so forth. So I would say that's really where we need to go to kind of really push through on the real-time surveillance. In terms of the, generally speaking, suicide does tend to track socioeconomic status. Now, how we measure socioeconomic status is quite complicated, as you probably know.
You've frozen, Mike.
I think his connection might just have gone.
Ah.
Do you want to leave it a minute, see if he...
Yeah, if he comes back. If not, move on.
If he can't get back in any questions, I can forward them on to him afterwards.
Yeah, what I could do is I could probably send you an email with just a couple of, an email those points to you, and then you could forward them on to him. I'd be grateful. Yeah. I'm afraid I've got to go because I've got to go to another meeting, I'm afraid. So.
Right. Would you be happy to do that as well, Mark?
I'm more than happy to do that, Chairman.
Right. Okay. Well, on that score then, let's move on to
thank you, Jill.
7, which is the provision of community inpatient beds at Clacton and private hospitals. Now, I know Anne was going to do this. Vicky, I'm sorry to have kept you waiting all this time. I think Simon is probably still there as well. But thank you very much for your patience. You're turning somersaults there.
Sorry. Perils of technology.
I'd like to hand over to you, Vicky, please. Thank you.
Thank you so much for the opportunity to attend today. It's been really interesting actually listening to the other speakers, so I've quite enjoyed participating quietly in the background. So I appreciate that members will have read the paper that we've submitted ahead of the committee. So just really to summarise a little bit before questions. The committee will remember that we completed an engagement exercise in around about 2018 to look at the future of community hospital beds on the Clacton Hospital site related to inpatient beds linking to the flow out of Colchester Hospital. So this doesn't link into mental health bed provision at all. And we had a great response. We had well over 400 responses with loads of different points supporting and with some very good and useful information around areas we should look again at. So as a CCG, we've used this feedback to review the proposal. And we no longer intend to close the beds at Clacton site, which was the original intention in the original proposal. I think this is a really positive story for how engagement has supported us in our decision making thus far, and how we want to continue to use engagement with the community to listen to the needs of our population going forwards, and to continue to review the use of the Clacton site as we go forward with the other developments on the Clacton site, which I'm sure we'll come to in the future. We've also been using a lot of the learning from COVID and the engagement feedback So we've been working on a plan that will be initiated in 2 stages over the next 5 years. So the first stage, post-COVID, because at the moment we've got a number of extra beds open on the on the community hospital sites in both Tendring and Clacton and Harwich, will be to return to a number of beds that are similar to the original bed base of the hospitals, but with a small increase. And stage 2 of that will be to start to phase an increase of those beds over the next 5 years to a number of around about between 77 and 80, depending on what the modelling suggests at the time, as we believe the change in demographic will increase the requirement to use beds outside of the acute hospital. So initially we've said we're no longer going to close all of the beds at Clacton, which I'm sure everyone will be pleased with. But what we would like to do is to change the use of the beds on the 2 hospital sites, so that we distribute them slightly differently, utilising more effectively the wards at Harwich, but while retaining a ward at Clacton. The reasons for this are that there are an increased number of single rooms on both the new ward and the existing ward at Harwich, and that gives us an opportunity to utilise those single rooms for things like maintaining patients' dignity at the end of their life, improving infection control, which is particularly important in this COVID period. And despite the fact that we've got a vaccine coming on the horizon, I don't think that we would underestimate the need to continue having sufficient isolation facilities for all kinds of isolation requirements, not just COVID, going into the future. The rationale for supporting keeping beds at Clacton also includes that we have spent quite a lot of time working on the pathways going into the urgent treatment service on the Clacton site, where the UTS is sited. And obviously patients are sometimes admitted from that UTS and from GP care into community beds. So we wanted to be able to make sure that patients could still access both care at their end of life and care where ambulatory care can't be completed, and they do need an inpatient stay for a short period of time, but that can be completed in a GP-led unit rather than having to go all the way to Colchester. We're also at the moment about to embark on some work linked to the UTSs that allows a frailty service to be delivered from the Clacton site, which linked to the inpatient beds will also give an improved opportunity for patients to stay closer to home. So our plan is to continue to engage on this work. Unfortunately, it's been slightly delayed by COVID pressures. We had hoped, after we spoke to some members of the committee in November, to have started a further period of engagement. However, we've been a bit delayed on that, so we are actually starting it now in December. But we're also going to be engaging with Health Forum and other patient groups to get this moving, alongside some wider comms to our patient community. I think in summary, really what I just want to say is COVID's changed the landscape in which we plan care, and our need now to retain beds across our health system. We know that the beds on both the Clacton site and the Harwich site are used not only by local residents in those 2 particular geographical areas, but are also used by patients who are being discharged from Colchester Hospital, who are Colchester residents as well. So it's important that those rehabilitation facilities are available for the entire system community, and that we've got the opportunity for patients where it is possible to be kept close to their home sites to be kept close to their homes. We also recognise that in doing this, what we didn't want to do was put any barriers in the way of the primary care development that's happening on that we've got an outline business case into NHS England for the Clacton site. The committee will be well aware that the CCG's got ambitious plans to rebuild a primary care hub that relocates the 2 GP practices onto the Clacton site. And we wanted to make sure that any decisions around the beds didn't prevent that from going ahead. So that is still going through the normal governance arrangements with NHS England. I think the other thing I just want to say is we really remain committed to having active health occupation of both community sites, both at Clacton and at Harwich, and this allows us to continue that planning. There will be a further requirement to plan the wider use of the Clacton site in the future, and further work on how we engage our community and council leaders on the development of that with stakeholders alongside the community. It will be really important to us for the future. And I'm happy to answer any questions, and Simon's obviously on the line to answer any questions as well.
You're muted, Gillian.
I'm using the one I normally use the one on the little one on the left-hand side, and I thought I'd change it this time. I've got Councillor Andy Wood and Councillor Dave Harris, please.
Thank you.
Thank you, Madam Chairman. Thank you, Vicky. And also thank you to Simon. I'm really pleased that you've listened to people about the Clacton site. I really am pleased with that. That is a good story. To be quite honest with you, since I've been on a councillor, you have listened to my concerns, and it's been really good working alongside you on that respect, because we can actually work together. It's brilliant. The question I want to ask, there's two questions. Well, there's one question I want to ask is, in July, I think, of this next year, 2021, ACE are actually losing the contract.
That's right, yep.
And I'm just wondering what effect it's going to have, because obviously their staff actually run the beds in tendering. So I'm just wondering what effect that's going to have.
So we're not anticipating it having any effect on the plans that we're putting in place. The rationale for that is because the procurement that's currently been undertaken around the integrated community care contract will take over these beds, and the participants and stakeholders in that are fully cited on our plans. So as a system, our urgent care team have looked at all of this, and so there's nobody that's not clear from the providers who'll be taking over the community bed services and the community services in general around what this plan is. So what we're trying to avoid doing is to try and avoid having staff having to TUPE more than once. So it's a bit of a balancing game to make sure that we don't go ahead and make changes that make staff have to go through 2 HR processes, alongside actually making sure that the beds can function and are available for our population's use.
Yeah, sorry, Jill, just an observation there. So, because obviously in tendering, we do have a problem with getting recruiting nurses. So hopefully you're saying that the ACE nurses or people that work for ACE will come over to the new service, and hopefully
absolutely
just with one, just not having 2 interviews and nothing like that.
Absolutely, and we wouldn't anticipate that anyone would have to go through an interview process for the jobs. What they may have to do is look at how staff are deployed across the 2 areas, but all staff will be guaranteed a job in the community hospital bed base. The location of that bed base may be the change in their location, but certainly not having to go through extra hoops that we don't have to outside of the TUPE process, which would be normal.
Fantastic, thank you.
Councillor Harris, then I have Councillor Stevenson after that, please.
Thank you, Chair. Thank you, Vicky. Thank you, Simon, for the report. I'm very pleased when I read this. It's a good news story, as you say. One of the thanks I want to give is for 6.2, where you talk about having a virtual meeting with the councillors, myself, Mark Stevenson, Andy Wood and Anne Brown, and I welcome that and hope that's soon. My questions are probably a couple of fold. One is about the staff and staffing, which you've just hinted at in the last answer, but is in the document with just a sentence. Would he be moving staff between one site and the other, logistically, or will they just be floating across, or will they be dedicated to each area? And the second question is, about the quality of the building. Now, I've been in the quality of building at Harwich. It's absolutely top rate. And I agree with you, the isolation rooms there are absolutely superb and very good. And I just had some building work down there, haven't you? So
that's right, yeah.
Clacton, of course, I visited a friend last November who was taken out of Colchester Hospital to rehabilitate at Clacton, which was a good decision for him because it suited his needs at the time and the clinical needs, but the wards were slightly different quality. Are there any moves to do any upgrades with the hub and things that are going on in the future that would improve that for us, please?
Okay, thank you. So yes, we'll be happy to timetable the virtual meeting at a time when it's suitable, and we can give you some further information after today. From a staffing point of view, the intention would be that once the staff have gone through the TUPE process and they've agreed a bed base on a ward, that they'll stay on that ward. So try and avoid moving staff too often. It has infection control implications if staff move between wards too much anyway, although you know, sometimes staff do have to move to support the other ward areas. What we've seen over the last few weeks, particularly through COVID, is that the mutual aid agreement between ACE and ESNEFT has supported the staffing in our community hospitals. And what we'd like to do is, once we've got these plans settled and the staff consultation completed, is make sure that any remaining vacancies are recruited to. We know historically that recruiting to the vacancies at Harwich has been less troublesome for the provider than it has been at Clacton. So we're hopeful that we can reduce the use of temporary staff, giving local jobs, and ensuring that we support the staffing with staff who are there regularly rather than temporarily. In relation to the buildings, I'm not sure if your friend was on Kate Grant or on SOP, but what you might not have picked up from the report is that Kate Grant was a Nightingale ward, particularly old-fashioned, really not suitable for modern nursing. And as part of our COVID precautions, we've moved Kate Grant out of that ward and moved them temporarily to another location on site. The intention will be to retain SOP as the ward, so St Oswald Priory, as the ward that will remain on Clacton site, and that's got a much better environment, although I accept not as nice as Harwich, because that's a brand new build. But you know, certainly getting out of Kate Grant has been one of the core reasons for doing this piece of work, because of its poor infrastructure and you know, very few places nurse in Nightingale wards now, apart from if you go to one of the COVID hospitals where they've had to do that. But you know, that's for different reasons. Certainly not something we'd want to do on a normal long-term ward environment.
Thank you, Vicky, and thanks for taking notice of all the engagement you've been doing. Thank you.
You're very welcome.
Do you want to come in, Councillor Stevenson?
Yes, please. Okay, a little bit confused in my head, so you're gonna, if you could just help me out, Vicky. So we've got the £15 million announcement from the CCGs about the redevelopment of the Clacton Hospital, and that's partly to do with bring the two surgeries, the Ramsworth, and I can't remember the other one at the moment.
Yep.
To bring them in. From reading this and from what you've said, my understanding is that we're going to reduce the amount of beds in Clacton to start with, take them to Harwich because they've got better facilities, and then the 5 to 10 year plan is to repopulate 80 beds. Now, what the bit that I've lost in is you don't say where those 80 beds are going to be, because the two hospitals are lumped in together.
Yeah,
it's very easy to sit there and say we'll have 80 beds, but you know, of the two populations, I think we are 4 times the size of Harwich. You know, so in theory, we would need 4 times the bed.
Sure. Although, so the population size is not the main reason for where the beds are placed. The bed placements will give us opportunities around the rehabilitation and the other opportunities that make a difference, plus the environments. I think I mentioned that we would plan to keep 1 ward on the Colchester site, and that would be to a maximum of 30 beds in total, and there'd be 2 wards on the Harwich site. which gives us the opportunity for making sure that the stroke facilities and the stroke centre are dedicated in the one area for the improvements that can help with the stroke rehabilitation pathways that we're expecting.
Okay, and what's going to happen with Clacton then?
So
I don't know whether I missed that in your response, but you didn't really refer to Clacton and how many beds that will have. Let's say in 10 years.
So in 10 years, the maximum beds that Clacton will have will be 30.
Right. So, and that will be the same as what Harwich has.
Harwich will have.
Guess I won't hold you to it.
The other side of the 77. Sorry, my maths is really poor when I'm under pressure. About 37.
Just wanted to raise something that one of the other councillors was unfortunately not able to be here. Councillor Brown went to your CCG meeting yesterday.
Yeah.
And one of the real risks that they identified was that you couldn't get enough nurses for these two hospitals. So if you're increasing the beds and you can't get the nurses, it kind of seems like you're increasing your risk. And I was just curious as to how you're actually going to, I know you kind of touched on it, but I don't see a real solution to it rather than saying we're going to recruit more. Now, if that was the solution, I'm sure we wouldn't have that problem in the first place.
No, and that's the rationale for phasing the increase, or part of the rationale for phasing the increase. Stretching the bed base to 80 during COVID has stretched our providers and their ability to support each other, which we accept, and everyone's doing a really great job at supporting those 80 beds for this period of time. But doing that longer term without having the ability to grow staff, to allow the opportunities of the health academy locally to support local people coming into nurse training, etc. We want to be able to grow those beds gradually. So that's why we want to go back down to 65 after COVID and then gradually come back up to the 80 so that we've got time to plan that recruitment, to work with our workforce team and to encourage our local population, hopefully, who might have been a bit inspired by some of the things they've seen on TV, to come into some of the medical professions locally via the Health Academy that Lisa Llewellyn, our Director of Workforce, and local university partners have been putting a lot of effort into supporting to help our workforce grow locally at the local place bases.
Okay, sounds like a good solution, thank you. Lastly, and I know Councillor Harris already touched this, but you are speaking to a scrutiny committee. You said you're going to hold a meeting with ourselves, Councillor Wood, myself, Harris and Brown.
Yeah.
And it'll be soon, but we don't do Woolly. Any idea when that will actually be?
It'll be early in the new year, if that's okay with you guys.
Thank you very much.
Right, Vicky, thank you very much indeed. And to Simon also. I see at the end of our agenda item that you intend to come back to a future meeting and give us an update on what's happening. So we shall look forward to seeing you as and when sometime next year. Hopefully the future by that time will look a little bit brighter than it is at the moment.
Let's hope so. Yes, thank you so much for your time, your questions, and your interest in this work.
Thank you so much. I'm sorry we kept you waiting, but we had a very heavy first agenda item, and it's only fair to give the presenters the time to present, and of course the questions, and that all takes time. So
absolutely,
much indeed. Thank you.
You're very welcome. Thank you, guys.
We've got Mike McHugh back. When you were in the middle of presenting, your screen froze, Mike. Councillor, you were replying to a question that Councillor Edwards put. Now he's had to leave the meeting, and I think he agreed that he would put something in writing or something. And Councillor Stevenson, you also said that you would put something in writing, or do you want to take the opportunity of putting your question direct to Mike now? It's up to you.
As Mike has come back, I think it's only right that I give it to him.
Right, over to you, and then we'll move on to the next agenda item.
Fair enough. Mike, three things. You talked about granular and real-time surveillance. Who's going to be the guy on the ground that records that? Is that going to be the police force, social services, coroner's office? Who do you envisage is going to be recording that? The second part was You talked about the working parties. I know you touched on this with Councillor Harris, but I didn't really hear the answer. I was hoping to hear, will you be including us as Essex County Councils in that working party? Yeah, and the third one, I'm just curious, we talk a lot about numbers and stats. If the three that you've identified, Harlow, Tendring and Colchester, had, and this is not probably a good way of saying it, reasonable suicide levels, would we be as high, or are those three districts holding the whole county up?
Yeah, thank you for those questions. So I'm really sorry, my laptop made me restart in the end. I don't know what happened. So yeah, the police will be the people who will record the data at the scene of the suicide. That's the first thing. And yes, you'll be welcome to be part of the working group. And then finally, the suicide rates in those three districts are high, but it isn't enough to push Essex as a whole into a higher rate, overall. So there's something going on, not just in those three districts, if you like. And indeed, if you were the national average, you would still say I wouldn't be comfortable with that. That would still mean we're still seeing considerable numbers. For example, if we were national average, we'd probably see 120 suicides per year in Essex, and that would be 120 too many, obviously.
Yes, sorry, I was just trying to ascertain whether we were skewing the average for the whole of the district, for the whole of the county. Thank you, Chair.
Right, thank you very much indeed. We will now move on to agenda item 8.
Chairman, just to jump in, sorry, Sharon from Health Watch would like to ask a question, if that's possible.
Oh, I do beg your pardon. Sorry. Sharon, over to you.
I do apologise. I've been looking for the electronic hand function on here, but I don't seem to have one, so my fault too. I just wanted to ask Mike, if I may, we're talking around the suicide surveillance figures and obviously concentrating Colchester, Tendring and Harlow, which we know have been particular kind of top tier concerns for some time now. But as close to go as last year, we were also identifying Malden as an area of real concern, but that doesn't seem to be figuring in the current data. So I was just wondering what had happened to change there, if anything.
From memory, and I haven't got the figures in front of me, but Malden's has been, fluctuating, and the numbers are actually quite small to begin with. So you can sort of become an outlier quite quickly if you get, a small increase. But yes, it was, coming on the radar. But I mean, to be honest, all the districts are going to, the approach is to look at all of Essex really. In terms of the work, you obviously try and prioritise where we seem to have the biggest concerns initially, and then kind of work away from there, I think.
Thank you.
Councillor Steve, did you want to come back?
Yeah, there was a follow-up question I completely forgot once I've established who was doing it. Mike, has the police signed off on doing the granular sort of identifying, or is that something we've still got to get confirmed?
It's still working. It's still working its way through the police. I mean, in principle, the police are want to get involved, and they already, when they visit a suicide, they have an unexpected death form. For the suicide surveillance requirements that we have, that form needs to be elongated, and again, the police are in principle happy with that. I mean, it's been signed off nationally. Police generally nationally are happy with this. We just have to work out logistically how we get it to work on a kind of logistical level, because it then has to be entered into an electronic database. So it's currently working its way around the different groups and so on within the police. But in principle, they see the value in this themselves. They see, because clearly, if we can reduce suicides, then it's obviously in everybody's interest, including the police.
Okay, thank you very much.
Jill, can I just come back? Jill, do you mind me coming back? It's just a question you just asked, Mike. Police, Is that all of Essex that has actually not signed off, or have we got part of Essex that have signed this off?
No, it has to be done as a police force. The whole of the police force has to sign it off. Yeah, so we'll be across the county.
Right, thank you, Mike. Sorry you were sort of, you lost the connections and everything, but we got you back, finished off the business. I'm sure at some future stage we'd like to have you back for an update. But as of this moment in time, I think all it needs me to do is to thank you very much indeed. And members will just press on with agendas 8, 9 and 10, which I think we can get through fairly quickly. So agenda item 8, nothing really much to report on there. Item 4 is, or 1 is self-explanatory, and then we have Humes. There is an invite extended to all members of the HOSC if they so want to attend their PAF meeting next week. I think it's on Monday, the 7th. Richard, I don't know if you want to come in on that at all.
No, nothing to add other than Graham has sent an email around to HOSC members with the invite.
Right.
And a copy of the agenda.
I did try to attend the meeting of Mid and South Essex NHS Foundation Trust yesterday. They're not on Zoom, they're not on Teams. Well, they might be, but this was coming through on Starleaf, and I tried every which way to attend and couldn't do it, apart from sitting there with my mobile phone to my ear, which would have been for an hour and a half. And I thought, no, I can't do that. So I stayed there for about 10 minutes and then came out. So our system just kept blocking it. Agenda item 9, which is member updates. Now, Councillor Egan messaged me a few minutes ago. She has another meeting, which I reckon is probably for Castle Point Borough Council, 2:30, so she had to go. Councillor Brown had connection problems, so she doesn't have anything to report on. Councillor Harris, did you want to update us on the Task and Finish group?
Yes, please, if I may, Chair. Members will recall that the joint Health and Ovary Scrutiny Committees, which is shared by Suffolk and Essex, with a joint meeting, has met, but not recently, certainly not since COVID. And one of the issues we were waiting for the Task and Finish group that we were on to meet to discuss how the Colchester new hospital for elective care, the shoulders, hips, knees, etc. Operations would be used to transport patients from the outliers, in other words, Clacton, Hendon, Harwich, Suffolk, etc. That Task and Finish group hasn't met yet, so I took the liberty, Chair, with Anne Brown's support, to write to the Teresa Harden from the Suffolk County Council, who has replied, Chair, formally, to say that she's actually asked the question of Susanna Howard, and she's also talking about an ICS, North East Essex ICS update as well, to report back to the joint committee. So I'm not going to let it rest, Chair. I'm going to, on your behalf, on this committee's behalf, on Anne Brown's behalf, I will wait another 7 days, since I've had that reply, 7 days, and then I'll reply again. That's something that I hope you would back me on, Richard, if that's okay with your good officers via Graham Hughes and Peter Randall, if that's okay, because I would like to ensure that we get that Task and Finish group in the diary, even if it's a few months away. We need to know when those dates are, really.
Yeah.
Chair.
Right, thank you very much indeed, Councillor Harris. So it's watch the space. Moving on to agenda item 10, which is the work programme. I'm not going to dwell on that. January, at the moment, it's autism services, and then February, East of England ambulance services, and so on. I'm sure more will come out in the fullness of time where that's concerned.
I'll just check with Richard, because he's only put a brief note in there.
Yep.
I was particularly, when you're talking about the GPs in February's meeting, I was particularly interested in what they were doing outside of the normal, you know, because as I said before, they seem to think they can just recruit their way out of it, and there's not enough GPs in the country to do that. So I don't want an update of them turning up and saying we're recruiting, you know, and we're going to give people a golden handshake and this sort of thing, when that hasn't worked in the past. I'm looking at really what the alliances are bringing, and then and the new way of thinking. And if they're not doing that, then that's where I'll be going down with the questioning. I just wanted to give them a good heads up. That's where we're headed, or at least I am.
Just to come back on that, so after the last hospital, we had a conversation. So all of that has been recorded and noted. It's just for the purpose of the work programme. It would have taken up probably half a page.
Thank you, Richard. I just wanted to check. Thanks.
Thank you for that, Richard. Right, agenda item 11 is the date of the next meeting, which is the 13th of January. We haven't any urgent business. So,
Jill, can I just come back on something, please, if you don't mind? Yeah. Could I ask for you, right, this, the health, the EPUT and the Linden Centre, could we get a report on what's happening at the Linden Centre? Because as I said, there's a lot of problems in there. And if you look at the CQC report that came out early this year, EPUT are poor on health, on their safety. So because of what's happening in the actual media now and everything, I'm just wondering whether we should send something to EPUT to just say, look, you know, we're aware there's a problem. Can you update us on what you're doing to solve that problem? I know it's going to court, but there's still other people. There's still a lot of problems in Linden Centre. Thank you.
Need some guidance on that, Richard, please.
I can put something together to send to them, and I can send it through all of you to approve, and then it can go off and it can come back either as they come back and present, or it's just received as a written report. But I'll put something together and send it around.
Okay, right. Thank you very much indeed.
Thank you, Richard.
Well, as I say, the next meeting is January the 13th. No more meetings until then. Cannot believe it's almost Christmas time. Doesn't feel remotely Christmassy. It's going to be very strange this year, but I wish you a Merry Christmas in whichever way you are going to celebrate it. And see you at some other